mindful of that and get going. So a couple of housekeeping items before we get into the presentation itself and start talking about applications. Just a reminder, this is a public meeting. So it is being recorded. It will be made available to the public. So just keep that in mind. We have also disabled the chat. And the reason why is just it's so that we can capture everything because it is public record. And so if you do have a comment or if you do have something to say, just unmute yourself, raise your hand. Don't be afraid to interrupt me if I'm talking, if you have a point to make. So we want to make sure that everything is on record. So today, the purpose of today's meeting is that we're going to review applications and end with a funding recommendation that I can then take to the commission in November. And so that's why we are here today. You all should have received the applications with their budget projection sheets and their narrative answers on the 14th. And so hopefully had time to look at them. If not, that's okay. We have, we'll be presenting the information to y'all today for discussion. So and just a reminder, there is going to be room for public comments at the end of this meeting. And so during this time where we're talking about applications, I'm going to be speaking directly to the Grant Advisory Committee. And so if you are in this meeting and you are a member of the public, please refrain from raising your hand or speaking until that public comment time is made available to you. So, okay, let's get going. This is the agenda, the schedule today. It's a very loose schedule. I did put time in there. I just wanted to kind of keep us on track. There are scheduled breaks in there. I do have a longer scheduled break through kind of the lunch hour, I guess. If we do need it. That being said, if we are, getting through them or if we are kind of in a rhythm with reviewing these things, this is something that can be adjusted. We don't have to stick to this. I want to make sure you all have appropriate time to step away from your computer. So if there is a time where you need a break and I'm talking, feel free to say, I need a break, and we can do that. So very loose schedule, but this is kind of what we anticipate, the time that we anticipate all of this taking today. So any questions on this or anything on the schedule? Okay, real fast, just for record before we get into everything, I'm just going to quickly take roll just so that we do have that on record. So Captain or Commander Eby?
Here.
Melanie?
Here.
Daniel Hoover?
Here.
Good morning. Moxie? I think Moxie's here.
Here.
Perfect. Orion? Orion is here, I think.
I am present.
Present. Good job. Okay. Mitch?
Here.
Good morning. And Grant?
Present.
Perfect. Okay. And let's get going here. All right. Let me just get situated here. So just a reminder of why we're here. I know some of you all have seen this slide, but this is why we're here. It's for the jail-based medication for opioid use disorder grant program. This did come out of House Bill 4002. And the eligible applicants that were able to apply were those that operated a local correctional facility, cities or counties, or any federally recognized tribes that operate a correctional facility. For this particular grant program, we did not have any tribes that did apply. And so today we are just going to be going over county and city correctional facilities. And then availability and duration of funding. So there is there a total of $10 million available. And this was put in this particular grant is a formula grant. And so we developed a formula, which we do have a slide on the funding table, just in case you all do need to have a reminder of what that looks like. And so the funding table was approved by the commission. And for this particular, the life of this grant cycle, it's just currently as it is a one-time solicitation, and the grant period is beginning October 1st and ending September 30th of 2025. So when we talk about grant period or project period, that's what we are referring to for this particular grant. Just real quickly, we went over this in the last GRC meeting, but I just, as a reminder, some of you may have some conflicts with these applications. We did talk about what this meant. Some of you have identified those particular conflicts. I've identified a few just in going through the applications, and then some of you have let me know that you have some potential conflicts. And so I've done my best to track those. If by chance, especially Daniel, I've tried to track the ones that you've talked about. If by chance I miss it, can you just remind me as we're going through those applications? And again, all you got to do is just mute yourself through the discussion and make sure that you don't participate. So
yeah,
I don't.
I can
Go
do
ahead.
that. I did want to ask you if I have, because my conflicts are related to providing TA for those jails. If I have additional information and there's questions by the other grant review committee members, should I unmute and help to answer questions, or should I not comment on those things?
Not comment on those things. So if you've identified yourself as having a conflict of interest, then just mute yourself through the entire conversation.
Okay.
This is something, and that's a great question. If this is something that will be helpful in terms of feedback to the grantee as they go through this is something that we would like to capture. And so potentially you and I can figure out a way to do that if it would be helpful for the grantee. But during that actual discussion in terms of recommendation for funding, please don't comment if that works.
Okay.
So,
thanks.
Yep. Moxie.
I wondered if there's any way for us to identify in between applications some concepts that we'd like clarified, like if something came up that involved technical assistance, could we ask Dan in general, like what kind of help could you provide to any program if they had questions about this or that? Like I have questions about affordability of medications. Would Dan be the person who could help with that, or is it the DOC or OHA or the CJC? Could he provide that kind of concept?
Yeah, I mean, that's a discussion that we can have as a group, for sure. Just I'm talking specifically about the applications that he's identified having a conflict with. So, and so those are discussions that we can definitely have as we go through. Just a note on this, and then Melanie, I identified one for you as well on my own. So if I'm wrong, please let me know. I'll let you know if this is something you feel isn't correct, then let me know.
Sure, it's
but
fine.
As I was going through applications, I just made a note of it. So just wanted to let you know so you're not surprised as we go through it.
Okay.
So, Orion.
Yeah. I mean, to Moxie's point, there have definitely been conversations with DOC about lower price point and using an MCAP purchase. And Rob Nutt was part of the work group that Representative Marsh pulled together. I know that there were a couple jails that reached out to them, and I was at their executive meeting. I was hoping to have like a meeting so all the jails could talk to their pharmacy to get that, but unfortunately I have not had time. But for the scope of these, I don't think that that difference in price will be that drastic to like at least make recommendations. And then I guess the second question is to you, Rachel. I mean, as a government employee, I don't see a conflict with any of these, but I have a lot of conversations across the state with jails on all their issues, including MOUD. So there definitely is probably information that I might have about this. And so you want me to like just hold that or just share
No,
things
you
objectively?
can absolutely share that. The issue with conflicts is if you're going to directly benefit
Yeah, I'm
from
not.
that particular entity of getting funds, right?
Right.
And so
No.
there are a
Okay.
few people who directly will benefit and have identified that. So
Right.
if you have
No
information, because
monetary
you've had-
value. No, yeah, nothing.
Yep,
Yep. Okay,
absolutely.
perfect.
Yep. Captain EB.
Yeah, I just want to kind of throw out, these are great discussions, but I don't want us to get ahead of what, really the goal of the board or committee is to, we have certain criteria we're looking at specifically under the House bill. And some of these topics, which are great topics that, as Orion mentioned, should be, brought up at, jail command meetings and stuff to talk about other options. Maybe a little bit more beyond the scope of what we're really looking at, which is their plan, and not necessarily breaking their plan apart and having them go look at different price points and stuff as, for the purposes of granting them their application.
Yeah, thank you, Captain EB. Yes, we're going to go over kind of the criteria and what we're going to ground this particular analysis in, and what staff grounded their analysis in as well. And so, Moxie, I see your hands up. I just want to make sure that if there is another comment on conflicts in particular. A few of you have identified them. If you haven't, okay. Moxie, did you have a question?
Yes, I do. It's about conflicts of interest.
Mhm.
I would say that I will abstain from discussing two of the applications
Okay.
because they're in my geographic area and I might end up working with patients from those programs. But I wanted to just say, as a concept, I would love it if the jails know that it would be ideal for them to try to contract with as many different agencies that offer buprenorphine as they can, because some places say, almost everyone says now that they're low barrier, but there are some places that have fired addiction physician in my town for prescribing bupe without counseling. And so, but they consider themselves low barrier and a safety net. And then there's another place that requires like 4 or 5 urine drug tests in the first 2 weeks of treatment. And they call themselves low barrier too. So just to try to make sure that patients are actually getting retained in care when they leave the jail, I would just ask that we try to encourage places not to only work with one partner, and especially to be try to be mindful about nonprofit versus for-profit. Thanks.
Yep, absolutely. Okay. Okay, so this grant is, and I know Grant Hartley, because I was just want to be clear, Grant, you talked about specifically about staff analysis being very prescriptive and having those discussions, and we were very cognizant of that. But I just want to kind of remind everybody that this grant itself is pretty narrow. There's some very specific guidelines in terms of what funding requests could be made and the criteria that needed to be met to receive those funds. Okay, and so this particular talks about eligible expenses. This is what staff used in their analysis and going through to making sure that it qualified as an eligible expense. And then we also went through our list of unallowable expenses where grant funds can't be used for particular things. And so this is just a reminder that this is kind of the qualifications or the criteria that grantees needed to meet in terms of their overall ask for funds. So please, and I can go back to this slide as many times as you all need if this is something that we need to review as we go through these, but please keep this in mind. This is in the bill. Okay, this isn't OARs. This is actually written in the bill. It's a pretty strict guardrail in terms of where their funding is. Part of the other requirement was that they had to submit a letter saying that they were going to follow this and what was laid out. And so this is something that, again, we can refer to as many times as we want throughout discussion, but I wanted to just remind you all, this is a pretty narrow grant program, okay? And then again, this is the application requirements. And so what we did was we built, particularly for the first three, we built questions that addressed these application requirements. And this goes all the way back for those of you that were involved in the OARs, the Rules Advisory Committee back in the spring. This is how this language was developed. This was in the solicitation, so grantees were aware of I'm sorry, this was not in the solicitation. These are in the OARs, but grantees were asked to address these in the narrative. And so this is where, when staff analysis, we went through, we were looking at answers for this. And so we're going to get into kind of what this means in terms of analysis in just a little bit when we talk about roles, but please keep these two slides in mind when we are going through applications. And again, I'm happy to go back to these as many times as we need to. So just for looking forward, kind of as the applications came in, there are 21 correctional facilities that applied for funding. It was about 6.7 million funds that were requested. And so there is some, a couple million that are left over from that 10 million that's available. We can have a discussion about what that looks like at the end of this and see what your all thoughts are on kind of the leftover funds. And kind of just as an overall, most of the facilities have some sort of established program and are asking for funds to either extend or expand services. And so a couple of them are in the implementation stage and trying to get their program off the ground. But for the most part, there is some existing program that they're looking to bolster through the use of these funds. Orion.
Do you happen to have like a overall landscape of like who applied and who didn't?
Are you talking about just like a list?
Yeah, I'm just curious, like which locations did not choose to apply.
I don't have it in a slide here, but I can get that by.
Yeah, that's fine.
How about we do this? I didn't put that in a slide. I have a slide I have a spreadsheet of who did apply. But what I can do is get that together for the end. If you'd like to see kind of next steps, if you'd like a kind of a picture of who applied versus who didn't, we can absolutely get that together for you. Okay. Captain Evie?
I will email you the list, Rachel, of the individuals who did not. So you will
Perfect. Amazing. Thank you. There you go. No, that's great. Yeah, we can get that information for sure. As I mentioned, this is a formula. And so this is the funding table. Obviously, not everybody on here applied, which we can talk about, but I did kind of this is just kind of a review of how these correctional facilities were, received the amount of funds that they did. We went through that work group where we kind of tried to determine what elements to use and came up with a funding table that reflected that. So just a reminder. Okay, and so this is, you all saw this, some of you that were here at the last GAC meeting saw this. Just want to remind everybody what our rules are for today. So for staff, we did review applications for completeness. We did get feedback from you all, from some of you all in terms of the application for the need for clarification. We tried to include that in this analysis. And so as we go through, those are things that I will be mentioning. And so really appreciate the level of engagement on that end from you all and taking the time to review them. And so we did, analyze and review the applications, and then we went through and identified any unallowable funding requests that both refers to what is in the bill and then also our unallowable list that we have in our grant administration guide. And so for today, the role for you all is to discuss these applications collaboratively. This is a long meeting today. We do have the space for that discussion. And so the kind of the one thing with this grant that is unique is the fact that it is so prescriptive, and there is some very direct guardrails for grantees. The applications were analyzed by staff for responsiveness. Okay, and I will get into a little bit more detail about how to ground your analysis or your discussions in a slide that's upcoming. But so please focus on whether or not they responded, not on the quality of the response. So the quality of in terms of eligibility or in terms of funding recommendations. The quality of response is where we would really appreciate any sort of feedback to the grantee that we can give them as they go through this grant cycle to continue to prop up and to continue to expand and extend their programs. And so please, as we go through this, keep in mind the difference for funding recommendation it is a responsiveness. Did they respond to the question? Did they request the correct kinds of things, and whether or not that is okay to recommend funding based on that. And then the quality of the response is where we want to rely on your all's expertise to provide feedback. So there is a difference in terms of the analysis and how it relates to funding recommendations for the commission. Does anybody have any questions on that difference? It's kind of a unique thing to this particular grant. Orion.
Is the feedback going to be given to applicants? And should we be giving feedback? I mean, one, right, we want to make sure that they're staying within the confines, but if there is any constructive feedback on the overall plan, is this an avenue to just share that with the facility? And is that shared then kind of just from CJC? Is that kind of an anonymous?
Yeah, no, we can share that. That's a great question. And so as we communicate with applicants, we're going to communicate with them about, their funding, their award, what was approved and all of that. We can also include feedback from you all in particular about if it's, the operations, just any sort of insight you may have, as they move forward and they go through this grant process. This is something that we can absolutely, we will take a record of it. We will take notes today, and we can provide to the applicant as they go through this process. So absolutely, it's something that we are looking for. I just want to make sure that everybody understands kind of the responsiveness part versus the feedback part. So the responsiveness to a question versus the quality of the question and what the difference between that is as it relates to a funding recommendation. Okay. And then the commission, as I mentioned, they will hear your funding recommendations in November. And then they are the ones that will ultimately make the decision for amounts and all for funding for all of the applicants. So any questions? Okay. Oh, Daniel, do you need the previous slide? Sorry.
No, that's fine.
Okay.
This is kind of going off of Orion's comment, actually, just to kind of remind this group that OHSU got opioid settlement board funds to do some jail MOUD program TA over the next 2 years. And so we have capacity to do that. Basically, the scope would be that we could serve 4 high needs jails in this 1 year period now, and then another 3 in the next year. And so if if this committee has really substantive program recommendations for all the jails, that's going to be far too much work for us to do for TA. But if there's like small TA needs for limited periods of time, then we're a good resource to be able to help with some of that. So just keeping that in mind, I guess, that we can help, but also we have limited capacity and we'd like to invest TA capacity for jails that are doing like the largest changes or a brand new program.
Perfect. Thank you for that. Yeah, and that just kind of the broader picture of this. I know that there's quite a few things happening in this realm, and so if there are things like that that will be helpful to these grantees, please bring them up when we're talking about feedback or we're talking about any information that might be available that might help them as they kind of navigate these programs. So, Orion.
Yeah, similarly, in that same award, the State Opioid Settlement Board is expanding with, I think, 9 mobile OTPs, and have put into the recommendation and urging them to collaborate and work with jails, so that everyone on this committee is just aware those are being stood up, and I'm sure, yeah.
Fantastic. Okay. All right, so for today's review process, so just a couple of things. Ground your review in the grant purposes that are outlined in the solicitation and the bill. So we've gone over those. So when you're looking at these, the staff analysis is going to be pretty straightforward in terms of the slides that we present to you. And so it really is your all's opportunity to have a collaborative discussion should you feel like there is a need for one with that particular application. Like I said, you all have access to them. So if it's something where, you want to have a discussion about providing feedback or anything that may be helpful to this grantee, this is the time to do that. Just please remember to remember the solicitation and the bill, also the grant administration guide, and the bill, again, for eligibility, and what's allowable and what is not. And again, those 2 slides that I went over earlier, we can go back to as many times as we need to. This is a formula grant. It's not a competitive grant. Oh, Daniel?
Yeah, apologies. I keep thinking of questions here, but
That's okay. No, you're fine.
I was going to say to Moxie that I appreciated your notes document.
Yes.
And then it also was making me think there's cases where some of us may look at the budget items and say, like, that seems like an expensive amount for that particular service or staffing. And is that something that we want to focus conversations around, or is that not so much our role? Like those line items could be very, very clearly eligible types of expenses. Do we want to be talking about the legitimacy of the vendor's price estimate of these things, I guess, in this venue?
Yeah, that's a fantastic question. So we give a lot of discretion to the grantees in terms of their ask, and in terms of their cost, and a lot of it has to do with the fact that their situation is local. And so we tend to, our view, right, from a CJC perspective is a statewide view. And so we tend to really rely on grantees to give us requests or costs that reflect their local situation. And this is across grants, right? And so we don't if there's a need for clarity in terms of what they're asking for, not necessarily the amount, but what in particular they're asking for, that is absolutely something that we try to flag beforehand so that we can have the information for you all for this. And so if there's something regarding that, we can absolutely have that discussion. But in terms of costs, we tend to kind of give them their own discretion in determining that. And the other part of this as well that is kind of a grant process thing for CJC is we recognize that as time moves, right, as this grant process moves through this year, things can change. And so most of our grants are on a biennium, and we understand that within those 2 years, things are absolutely going to change. Within this year, we don't know, right? Like we had a pandemic in the middle of a year and it flipped everything. And so we understand that there are going to be needs that are going to change. And so we actually allow them to move funds in between categories if that's something that they need to do. And so does that make sense? There's kind of a less of um, a need for across the board costs that make sense, and there's more of a need for the local communities to determine their costs and also give them the flexibility to adjust if needed. And so for your all's purposes, if there's a need for clarity in what they're asking, absolutely, we can do that. Does that make sense? Does that answer your question?
That's answering my question. Yes.
Okay, perfect. Orion. Oh, Orion is not sitting. So Moxie.
Yeah, I just wanted to say that I think one of the reasons I feel concerned about the potential overpayment of clinicians is that it can be really hard for someone who's not in healthcare to look at healthcare costs and say, how much should I be willing to pay? And so when purchasing something really complex, it's easy to be taken advantage of. Like, not that these places are doing that. I mean, in rural places, the cost can be really high. The cost of serving one person in Portland is probably a lot lower than out in Malure or something. So I just wonder, for the places that didn't itemize their costs, they just say, for instance, we're going to pay 200,000 to this clinic or this OTP. How much of that is going to staff? How much of that ultimately could be going to profit versus to serving more patients, especially when these medicines, some of them cost a lot of money. And we could also sometimes help with purchasing. So I'd love to see itemization. I wouldn't withhold funding, but I would want to help the jails understand like what reasonable rates look like.
Yeah, and Moxie, this is great feedback for us and also for the grantee. And it's also something if this continues, because it is a pilot program, if this continues, the data piece, I think, will also be helpful in informing that, right? With how many people are served and that kind of within jails, I think we'll get a better indication of how those treatment prices can potentially match how many people they're treating. And so this is something, that's a great point. It's something that we can continue to kind of monitor as we kind of move through this grant and it gets off the ground and moves through a little bit more, gives them a little bit more opportunity to collect that data. So no, that's a great point. Grant.
Yeah, thank you. I'm actually following up on two of Moxie's comments. The first is that what was just raised. I'm curious though, when you have a lump sum just given to a medical provider, how is CJC ensuring that those are all allowable costs? Both under the grant but also under CJC's general rules.
Yeah, so that's also a great question. We do have financial reporting that they are required to submit every quarter. And we get more detail from them at that point in terms of what they're paying for. And so there is the allowable and unallowable discussion doesn't stop here, right? It continues throughout the life of the grant. And so that's something that we track for every quarter that they are required to submit expenses. And so we track that on our end. So on its face, we try to give them as much discretion as we can in terms of cost and in terms of local cost. And then on the back end, we do track those things to make sure that what they are paying for and where their funds go are still allowable. So we kind of pick that up on the back end.
Okay, and then I guess the second part of that is with regards to the medication cost, especially with the injectables. I mean, there is a dramatic difference. I mean, 2,800 in one jurisdiction, 1,500 in another. Are there at least sort of questions being posed to these counties about why that difference exists? And, you know, I just want to make sure that the funds are being spent appropriately.
Yeah, that's a great question. And I think that is a discussion. This is something I talked to quite a few grantees, just, you know, giving them feedback on requests and applications and things like that, because some of them had not done this before. And that was a conversation that I had with quite a few of them, is the difference in price among jurisdictions. And I noticed that as well, that there is, depending on where you are, depending on who you're working with, they do cost, there is a different in amount. I think that is a discussion that needs to be had kind of outside of I think it's a very important one. I don't know why it is the case. But I think it is a conversation that absolutely needs to continue to occur, just because there is such a huge difference in cost across the entire state. And so I don't know. I mean, we can obviously, you know, have those discussions here, but I also think, to your point, it would be something that I think would be helpful to have in other places as well, because I also noticed that just the huge difference in discussions with grantees, and I'm not sure why. So, Orion?
Yeah, well, I think there's price gouging by some pharmacies, especially for those long-lasting injectables. Kind of summarizing from Molly's point and Grant and Dan, like maybe in that feedback that's given to counties, if you see costs that are exorbitant, there just could be like mention of, you might consider the cost of this at that time. I will plan to bring DOC to one of the jail commander meetings to share purchasing from them. And then, Moxie, I'm looking through your notes. I just want to be clear that DOC can't offer 340B and CJC can't offer 340B. The reason that DOC is being given 340B pricing is because they have agreed to opt out screening testing for STDs, HIV, Hep C. And so that's what they had to do, and that makes it an eligible patient. We are trying to work to see if there's jails that can come on and benefit from 340B too, but it really needs to be a broader discussion, and it's not something that DOC can just immediately pass through. We would have to certify the jail as an STD clinic, basically, is what we've done for DOC. But that would make, you know, so one, just purchasing from DOC, they have an MCAP. It is about $1,200 for most of the injectables. They're switching to Brixadi. If then a jail also became a 340B entity, it's about half that price.
Yeah, and I think, to Orion's point and Captain Eby's point, kind of in the beginning, these discussions are incredibly valuable to continue having, because I think MOUD is not going anywhere. I think these types of programs are going to continue to grow. And I think, as you know, and kind of the community is still trying to figure these things out in terms of how they are applicable to you know, the jail environment. And so this is a discussion, to both of y'all's point, that could be had in something like a jail commander meeting or other environments where it's really important. To Grant's point, I don't know why there is a difference in pricing, but I think it's really important to continue those conversations. I think for today, you know, there's not a whole lot we can do in the current environment with the current asks, other than, you know, continue to inform and continue to provide feedback to grantees about some potential options, or potential avenues that they may take for those prices to, you know, maybe go down in the future. So.
And Rachel, I'll just add that, you know, I think if we make that determination about the scope and the ask of it, it just means that if they can figure out a cheaper option, they can reach more people.
Absolutely.
Right? Like,
Yep.
We're not making that determination, and you know, they have a good plan. We can
Yep.
maybe help them save money so they can reach more of the need.
Absolutely. Yeah. Yep. That's a great point. That's great feedback. So, Moxie.
I'll be really brief. I would say, in addition to those special discount programs, probably one of the fastest things that the jails could do is find all the specialty pharmacies that are willing to deliver to their areas for injectables, and then ask each one what the cost would be. Because it may be that one place went with a certain specialty pharmacy that charges very, very high rate, but they deliver quickly, versus some other place could bring you 10 injectables at a, 2/3 of the price. So
Yeah, absolutely. Okay. Great discussion on this. And I like I said, I feel like this is something that needs to absolutely continue. Okay. So kind of going back to, Orion.
I was trying not to say anything. There also are some pharmacies that I think are directly reaching out and targeting jails that I don't know are the. I'm impartial to pharmacies, but I know that Diamond Pharmacy also then offer like a EHR light type service that is a benefit to some jails, but they also are rather expensive. But
Okay.
yeah.
Okay. So for today, all these are great questions. The collaborative discussion, I think, is really important. The feedback to grantees, just in continuing to inform them. Like I said, a lot of them are just looking to expand or extend. And so things like this, where they are looking for more funds, would be helpful. To Orion's point, like the more people they can serve, the better off these programs are going to be. And so this is the kind of feedback that we can provide, and also continue these discussions beyond this particular meeting, I think is important. So, okay, so note that this is a formula grant. This is not a competitive grant. And so for those of you that have experience in working with grants, there is a big difference in those. And so, every applicant was given an amount that they could request up to. The evaluation for you all today is the responsiveness to the question. And so that is why, when I mentioned earlier, the staff analysis in terms of the presentation is pretty simple, pretty straightforward. So there is room for discussion. And then, like we said earlier, the quality of the answer will allow for feedback. And so this is where, in particular, we can rely on subject matter expertise to provide feedback to these grantees as they navigate this grant cycle. So, any questions on anything we've covered so far? I'm about to get into the applications themselves. For those of you that may have the Google Drive up, I'm going in alphabetical order. And so, a couple things to note. We had flagged a few things to get responses from grantees. We gave them a deadline. Today's Thursday. We gave them a deadline of Tuesday to get back some answers that we needed, particularly on budget projection sheets and things like that. So they were, everything was updated in the Google Drive yesterday. And so everything is accurate. So and I'll let you know as we go through them, this was updated, this was changed, and here's why. And so if you are, looking at something that doesn't look completely familiar, that's why. And so I'll make note of that, but we did flag a few things that we needed feedback on. Okay. Any other questions or anything before we get into the applications themselves? I also want to just note, and again, this is why I always set up an agenda and then I tend to ignore it. So I apologize. This is why, if you do need a break, we are an hour in. If you all would like a 5-minute break, now that we've set this up and we've had some discussion, if you all would like a 5-minute break before we get into the applications, and then we can kind of go through and see how our rhythm goes before we get another one. This might be a time to do that if you'd like to get more coffee, if you'd like to just kind of step away. Okay, perfect. Let's do like a 5-minute break. Hold on. One question. Ryan? Sorry. I think you're muted, Ryan. There we go. Maybe. Still can't hear you. Can anybody hear him? I still can't. Okay. How about we do that? Hold on. Here. It's on my end, it says you're muted. And
Yeah, it might be something with just
Okay.
not linked up to audio. Yeah.
now I can hear you.
No, that was me.
Oh, that was
me,
you.
Ryan.
I'm sorry.
Ryan, I don't think we can hear you.
Yeah.
What if we took 10
Why don't we do
minutes
this? Why don't
and
we
then
take
really
like
dove
a
in, like started at 11 or at 9?
Yeah,
And
we
then
can
that
do
would give
that.
Ryan some chance to figure out
Yeah.
his audio issue,
Perfect.
and I can
Okay.
drink some more coffee.
Perfect. All right, let's take a
Okay.
break. We'll come back at 9 and we will get into these applications.
Ready to work. All right.
Yep. All right.
Thank you, Rachel.
Yep.
Can you hear me now? Okay, thanks, Grant.
Yep.
All right. And Rachel, just real quick. So when it comes to my county, do I need to step away or tune out, or can I just like listen but keep my mouth shut?
Rachel, you're muted now.
God, thank you. Yeah, just mute yourself and don't talk. Yeah.
Okay, sounds good.
You're good.
Perfect.
Okay.
Awesome. Thank you
I
so
will
much.
Yep, of course. I'll see everybody in a little bit.
Captain Eby, how are you?
Fabulous. Busy as always, but good. How are you doing, Ryan?
Pretty good for whatever day this is. Thursday.
Sure, we'll call it Thursday. Let's go with that. Hey, Rachel.
Yes.
And again, I'm not sure how you're going to do the process. I don't want to belittle this, make this any more complicated. Suggestion I would have is just each one we look at the basic questions we have to do as to whether or not to approve it. And then after that, if people have, what you're talking about is you guys taking some notes or suggestions, do that after, because we could get into too much of the weeds.
Yeah.
And not really think about, okay, are they meeting the minimum to get the money, the grant approval? And then obviously give opportunities if there's that feedback for you and that.
Perfect.
That's my 2 cents. That's all it is.
Yeah, no, that's perfect. Yeah, each one has 2 slides. And so we can go over it. Like I said, the first slide is exactly that. Here's the criteria they met. And then the requests. And so we can, the process for kind of recommendations is just consensus. And so we're not doing any sort of formal vote as we go through this. And so, yep, we can absolutely do that. So
I think that's a great plan, Rachel
Yeah.
and Captain Eby. And then let's see how the first several go. If that feedback part is taking too long, we could also then go through and review for content and approval first, and then go back to do I could also see this group going down some rabbit holes of
Yeah. So my job
feedbacks.
is to corral that.
Okay.
So, and to keep things moving. So yeah, so feedback is super important, but yeah, want to make sure that there's, opportunity for each, applicant to be heard. And also just as a reminder, when we talk about feedback, specifically, if we are providing feedback, we do have to be consistent, right? And so if at the end there is, something that you think is applicable to everybody, we can also do that as well. So, yeah, I will prevent the rabbit holes as much as I possibly can, but I think that's a good idea in terms of process from Captain Eby. So we'll go through alphabetically. If you have the Google Drive, I'm pretty sure it's in alphabetical order as well. And then we'll do did they meet, is there responsiveness there? Did they meet the criteria? Go through what they requested. And then at that point, I'll ask for any feedback. So is everybody back? I just want to make sure we're still, I think most everybody is on camera. I think the only one, Melanie, are you? Yep. Okay. There's Melanie. You don't have to stay on camera. I just have to be able to see you so that I know we didn't lose quorum. So you're fine. Okay. Let's get into it then. So the first one is, Baker County. And so again, this is kind of, how everyone is going to be laid out. This is the kind of the familiar slide that we went over in our last meeting in terms of the information that you all needed from us. So just to kind of walk through, to Grant's request in the previous meeting, we did kind of set out the application questions. The last 2 are technically not questions, but they were requirements, criteria. So those are included. And then what the application requirements are, and then whether or not they were met. And so staff answered that question. This is something where you all can then verify whether or not those questions were asked. Again, quality is something that we can provide feedback on. And so this is kind of the purpose of that little table on every applicants as we review them. So Baker County is partnering with the health department and a treatment provider to provide medication for those with opioid use disorder. In terms of the proposal overview, tried to be very broad. We can get into specifics if we need to, but I just tried to give a little bit of an indication of what they're going to be doing. They do have an existing program, and their allocated funds were 192,735. And so their overall ask, they did ask for personnel. They do have some money in contractual for a treatment provider for particularly for assessments. They did ask for storage and then injectables under supplies with a little bit of admin. So any questions on Baker County?
No, I think based on the what I read in the criteria set forward, they meet that, and I would agree that they would receive or recommend that they receive the funding.
Funding? Okay, perfect.
I would
Any
second that.
feedback or any points that want to be made for this application?
I think
would-
that
Oh, go
I was
ahead.
gonna say, I think that maybe
Yep.
Moxie actually pointed this out. I'm very curious if like those contracted services will kind of decrease once you know, the carceral benefit comes through, or if like we
Mhm.
can start, you know, with those waiver programs, just because and where else that money might be able to be redirected in that time period.
Yeah, so that's a great point. This is something, and this is something that's probably going to come up quite often is the simultaneous, the things that are moving at the same time. We're going to have to kind of figure out. This is why, kind of going back to the discussion earlier, we do allow a lot of discretion and also a lot of flexibility in terms of where their funds go. So that's a great point. But yes, this is something that is probably most of these applicants are probably going to have to adjust for as this everything that's moving all at the same time comes to fruition. So absolutely.
And the waiver won't be in place during this grant period. It'll be January of 2026, so before it is actually implemented. So this was really in the legislative concept with Representative Marsh. This was supposed to be some smaller funding to bridge that, you know, hopefully there would be more sustainable funding come
Yep.
the Medicaid waiver.
Absolutely. Moxie?
I just wanted to say I approve of their application and their funding as is, and I sent suggestions as with all the applications in the document yesterday.
Okay, perfect. And yes, thank you for that. We will make sure that feedback is captured for sure. So, Grant?
Yeah, so I think we should approve this application, but I just with regards, I mean, I will say I was a little concerned by the lack of responsiveness altogether. I mean, for question 4, describe how, you know, your program aligns with best practices. It's not does it or doesn't it, but their answer seems to be it does, though it doesn't really explicitly even say that. And so, you know, I hope that there will be, you know, my feedback would be to look into best practices and, you know, make sure that the program actually does align with those, because I don't see any description of how it does align with best practices.
Okay. Thank you for that. And again, this is something as well, it's going to be helpful for us as well, especially with a couple of the last couple of questions in the application in terms of data and in terms of how we can reflect that. So that is great feedback. Orion?
This is going beyond the scope of this absolutely approved Bakers, but it might be something for CJC to consider if there was a panel to come up with some best practices. There's a lot of different ones out there, and so can be for further father.
Yeah. Yeah, that will be that's good feedback in terms of what we're looking at if this continues, right? If this is a grant program that shows life beyond the pilot, that is something absolutely I think would be beneficial for us. So okay. Looks like there's consensus with Baker County in terms of the recommendation, captured the feedback as well. So we will then move on. So Benton County, just a note for Benton County, their letters of commitment and their statement on using the grant funds was fantastic. I don't know if any of you all saw that, but I just kind of wanted to give them kudos for that. They currently do have a detox program. They are just using it to develop protocols and expand kind of their current program that will address opiate use in particular. So it's existing, and then their allocated funds was 148, 167. In terms of the responsiveness to the questions, staff does indicate that we felt that it was met, particularly those last two. So good on them with taking the time to answer those particular requirements. And then in terms of their ask, with the way that they're setting up their program and they described it, it is all medication, in particular with a little bit of safe storage as well. And so again, their total recommendation for their request or their ask is 148, 167. So that is Benton County. Any particular feedback or discussion on this application? Mitch?
I was a little, I think, confused in their language because they had this sentence that said that they only will allow MOUD for people that already have a prescription, but then it kind of seemed like they were suggesting that that was changing, but I couldn't figure out if that's what the purpose of this is for or if I was misreading that. Yeah.
Okay. So is that something that is that something that you want clarification on, or is that something that you would like feedback on? I also noticed that as well. It did seem like I don't know if that was part of their expansion in terms of this is currently what they're doing and they're planning on expanding. It's kind of how I saw it. But this is something that if you'd like to provide feedback that's something that they should do, we can absolutely communicate that to them when we discuss their recommendation.
I guess maybe a little bit of both. I'm just kind of
Okay.
thinking about that second bullet point saying that that must be kind of describing planned coordination with an MOUD program. And so like that's kind of where like I'm not sure if they are planning the coordination or if it's just they will coordinate if it's already existing, I guess. So like that would be helpful.
Okay. Moxie?
I think it's great that their application was really strong, and I wonder with regards to coordinating care outside, their budget was all supplies, and I wonder, is there any room for the CJC to talk to them and say, could we budget something for you for administrative costs or for somebody to come in and do screening and help identify new cases of untreated OUD? Because if they're restricting their budget to only supplies and their total budget is low because of that, we might be able to give them more money and give them some latitude to develop that program.
Yeah, that's great feedback. This is something as well, when we talk, so in terms of extra funds, just because it is a formula, they could potentially move it into administration, but as it is right now, this is what they're requesting. But that conversation or that kind of conversation is something that we can have when we talk about the supplemental, because there is money that is still there. And so in terms of uses, I think that is a very valuable conversation to have in terms of building their program. So Grant?
I guess the only two things I had, the first was they forecasted 11 to 13 AICs per month. And, what I wasn't clear on was whether that was what they were forecasting the need would be, or whether that was a capacity issue. And so, I think obviously that's something we'll find out in the reporting, but it was something I wanted to note. And then the only other was what I mentioned earlier was just their injectable is 2,800, which is, just almost twice the price of other jurisdictions. The other jurisdictions, I think there was some variation between them, but this was clearly the outlier. And so I'd be very curious how they were sourcing those meds or where they came up with that amount.
Okay. Yes, that's something that we can take note of for sure. Yes.
I can comment that the 2,100 is more like a usual price without the corrections discount for Sublocade. So it would be helpful if they could just find out how to get the correction discount if they're planning to use particularly the Sublocade brand.
Perfect. Okay. Dan, that's great feedback for them. Is that something that they would be familiar with if it was worded that way, or is there a more like formal, is it known as the corrections discount?
Melanie, what do you think? Would you there's a specific like purchaser you have to go through
Okay.
that offers this discount, and I
Yeah.
think Indivior will tell the manufacturer will tell people in corrections how to get the discount, but
Yes. Yeah. And that was going to be my suggestion, just
Perfect.
suggesting maybe some technical assistance on how to reduce the cost of the medication, because it is possible.
Okay.
And I also want to comment to Moxie's comment about the what happens when they release from custody. They actually have a plan for a warm handoff with the health
Mhm.
department that's going to be providing services. They put that in their application.
Yeah. Yeah, they do have a pretty strong application in terms of just answering across the board, and their plan to make sure that there's treatment covered across while in and while out. So I was impressed by that for sure. I will definitely the correction discount. I may need a little bit more information, but this is fantastic feedback to give them in terms of lowering cost. So, okay. Any other comments, questions about Benton? Does any, is there a consensus that this recommendation go forward as is? I'm seeing some nodding heads. I don't see anything to the, okay. Perfect. All right, Clackamas County, Captain EB, you identified a conflict on this, and then Melanie, I identified this one for you. So if I'm wrong on that, let me know. But their overall proposal, in addition to an existing MAT program that supplies medication, the jail has committed to continuing all patients entering the jail on methadone. This is an existing program, and the allocation was 372,771. According to staff, all criteria was met. I also want to note, and because I know as we kind of go through this, just to kind of get a little bit of a rhythm, the proposal overview is really broad. And so there's a lot more detail in terms of what their program is actually doing in the application. And so if there's a need for discussion on more detail, please let me know. I just tried to fit it onto a slide. Okay. But according to the staff analysis, all criteria was met. And then their ask is personnel, a healthcare administrative service manager, and then they do have a treatment provider. And in their budget projection sheet, they go into pretty great detail on terms of their ask and in terms of how they're partnering with their treatment provider and the services that will be provided. I did not put them on here, just various services from CODA. But if there's any questions or clarification or any need for feedback, the budget projection sheet does provide that. So oh, yep, go ahead.
Can I ask clarification? And to be completely transparent, I haven't had a huge opportunity to really dive into the applications
Okay.
in detail.
Yep.
Is CODA also like guest dosing and starting other patients? I mean, I love when the community partners are coming in, but I just want to make sure that they're meeting everyone and not, that there's not any lapse, with other patients coming in. Dan, you probably know this.
Yeah, so I think the current situation is that it depends on which opioid treatment program the patient is established with, and then the jail has to go to the various different treatment programs in the Portland area, obtain the medications, bring them back. If it was like a out of area program, they could arrange for someone to courtesy dose that's more local. But this is going to streamline where CODA would essentially like take over all of the patients who come in on methadone, regardless of which opioid treatment program in the metro area that patient is at for usual care. And so the jail doesn't have to run courier transport of methadone back and forth to various different spots and rely on care coordinating with all those different clinics.
Is there still linkage to people returning to their opioid treatment of choice at release, I guess is my question with that. It's not going to kick them off treatment, or is information going to be shared with their providers? But this is more like feedback than it is.
Yeah,
scope.
I would think naturally, but I'm not sure if it was specifically said in the application.
Orion, can you repeat that again, just so I can capture that?
So if CODA is going to be treating all patients for the jail, would urge the facility to consider some form of notification and transfer back to the providers that they have in the community at release, so that the provider knows they haven't fallen off treatment, and that the person, it's not saying that like just because you went to jail now you're going to be a CODA patient, but to let them have that autonomy of continuing their treatment with whoever they want.
Okay. Grant, thank you, Orion.
Oh, I think Moxie was next, actually.
You what? I'm sorry.
I think Moxie was next, actually.
Oh, I'm sorry, Moxie. Sorry.
I'm deeply offended. No, I just wanted to add that OTPs will often have patients switch from one to another or back when they move, or they just get dissatisfied with their care. When people go into corrections, though, there's no reason that they won't share that information with the jail. But one difficulty arises when the patient comes into jail at night, or they come in on a weekend, or somebody's delayed in their response at the OTP. So this is totally beyond the scope of this meeting, but I've talked with the SOTA, and he's amenable to developing a central registry for Oregon, which would help everyone a lot, because then it's sort of like a PDMP where you can go online on a central registry in some states and say, does Joe Smith go to an OTP or not? And they can see where they've been going. I don't know if it includes doses, because I've never worked with a state that had a central registry. But if we had that, it could really speed up the intake process for people who are in a different OTP other than CODA.
Perfect. Okay. Grant,
that's
did you
a
have
great
something?
idea, and maybe that could be something that we take beyond this meeting, that I can also push with John and others that might have purse strings. Just think about developing that.
For sure. Grant, did you have something?
Yeah, I was really going to just echo what Orion had said about the release and transition planning. I think CODA is an excellent organization, and frankly, this was one of the applications that I was most excited about, because it really offers a whole range of treatment options, and I think is pretty comprehensive. And I do appreciate bringing in an outside treatment provider into the facility. But I would want to make sure that that transition planning includes the inclusion of other treatment providers, especially those that are, culturally appropriate, culturally responsive. I think that that's important. But yeah, that's all I wanted to say.
Perfect.
I did find a few lines in the application question 2 that refer to some things pertinently here. One is just that CODA is taking the care in the umbrella of courtesy dosing. So usually when we just use that term, where it's saying CODA is doing the dosing while you're in jail, but then the expectation is actually that you would return to your OTP that you were at previously. So I think they have that assumption, not that everyone's going to leave jail now a CODA patient. And then in their step 7, they mentioned that release planning will prioritize continuity of MOUD and additional supports to maintain community integration upon release, and that could include release to residential care. And there's a mention of CODA also has their own residential facility. But I think they're talking about some of those additional release supports.
Perfect. Thank you, Dan. Any other comments or questions, feedback for Clackamas County? Okay. Is there an overall consensus that this recommendation move forward? Okay, perfect. All right. Next we have Clatsop County. Clatsop County's program is voluntary. Each adult in custody is screened and assessed. The completed assessment is then forwarded to a prescribing physician who prescribes the appropriate medication. It is an existing program. The allocated funds were $309,436, and staff did the analysis and felt that they did meet all criteria in terms of responsiveness to the questions. 1 second here. Sorry. I got to make sure I'm on the right application as well. And then their overall ask, they do have some personnel, corrections deputy, a jail nurse, some contractual services with a treatment provider, also with mental health services. Most of their supplies is for injections. And then I just want to note the statewide training was something that we flagged. They did request this. We asked for more specific information on this. And it wasn't a specific like mood training. And so they just requested that we move that money to admin rather than keep it in training because they couldn't identify one that was specific. So didn't want to confuse because that is in the initial ask, but in communication that we flagged, we did update that. But the overall total recommendation is $309,436. So any questions, feedback for this program? This application was also very thorough in terms of their answers as well. So Moxie?
I really liked it, and I really like contingency management. I just was curious about the funding streams and whether there's any concern about compliance with regards to using contingency management and the concerns that come up around federal anti-kickback statute. We're not supposed to give patients money to get treatment. There are some places that have gotten exceptions to that, and if you're not using certain types of funding, it probably doesn't matter at all.
Yeah, that's a great clarification. Sorry, I meant to bring that up. We did flag that as well. And this, when in the conversation with Clatsop County, it is an incentive. And we do fund incentives. The way that that process would go is it is an incentive because it is a voluntary program. It would go to commissary where they could use it if they didn't use it upon release. It would go back to kind of to this pot for incentives. It also would be directly for commissary, so it wouldn't cover anything like fines or fees or anything that was attached to that person when they entered jail. So hope that answers your question. For us, we do fund incentives as long as they are allowable under state and federal guidelines that we have to follow. So yeah. Grant.
I guess the first feedback I had is they have these two screening processes, and I don't know why the first is necessary. They have deputies essentially asking SUD questions and then medical staff doing a separate assessment. I just don't, obviously the defense attorney in me is always concerned when deputies are asking questions about things like this. And I do think it's for a medical purpose. And so my feedback would be both to kind of streamline the process, but also for protection that person's constitutional rights to just use the medical assessment instead of the deputy's assessment. And then the second part is with the contingencies. I really appreciated that. I will say that not requiring it to be spent on commissary and not releasing it to the individual when they're released. I would be curious to hear why they felt like that was important. And also, I'm hoping that when they say it's restricted to commissary, that would also include phones, because telephone calls are incredibly expensive
Mhm.
in custody, and often facilities will break up commissary from phones,
Mhm.
often because it's a private provider for the phones. And so I think that especially as someone going through recovery, it's important to be able to talk to your loved ones. And so, yeah, that's the other note I would make.
Yeah, that's great. We did not ask that question in terms of detail of commissary, so it is something that we can circle back to and just say that is feedback from y'all to include phones. We also did ask that question specifically if they are able to take the funds with them. And they just said the way it was currently structured is it would just go back into a pot of money for people who were volunteering. But they did say for those people who did receive that money, they were encouraged to spend it while they were in. And so this might be the phones, if they're not included, might be a way to continue to encourage that. So that's a great point and something that we can absolutely provide for them. So, Daniel.
I had three things actually, but first, just to respond to Grant's comment with some background about jail booking screenings. The deputy screening or officer screening is often happening immediately, essentially at booking, and then the medical screening process can be over 24 hours or sometimes a little longer, depending on the jail. So usually when I hear this kind of process from jails, they are aware that they want to do a thorough medical screening, but the deputy screening can just identify withdrawal sooner, and potential candidacy for the program, et cetera. And then number two, about the contingency management anti-kickback laws, I don't think it applies because they're not billing Medicaid for any of the services that they're delivering in the MAT program. It would be interesting if that changes when the waiver comes in. And then a comment about CM, that we don't have any really established best practices for CM in jails. And so I'm curious to see how it goes, basically, but I'm not going to make any recommendations about how they use the CM in jails. They do have institutional experience at Clatsop Behavioral Health using CM in the community. And then I had one kind of technical comment about their question 4 response, where they said that people need to meet criteria with at least a 1-year history of substance use and satisfying CFR 8.12. And I think they're referring to some requirements for initiating methadone maintenance, which would not apply for their program. So just the TA could basically inform them that they don't need to hold to these requirements about a 1-year history of opioid dependency.
Okay, that's perfect. We can absolutely pass that on. So is that all you had, Dan? Sorry, I didn't mean to cut you. Okay,
Yep.
perfect. Moxie? I think you're muted, Moxie.
Yes. I was thinking about the issue with what Grant raised about patients telling a deputy that they've been using drugs. Is there any law that protects the patient against having that used as part of the legal charges against them? Like, is there anything that is in place that would keep that separate from their reason for incarceration or sentencing in the future? Like, if they stole a car and they come in and they happen to tell someone, I use fentanyl, but then is there any way to keep them from getting charged for like fentanyl possession or intoxicated driving or things like that?
Grant, I'm going to let you take that one.
Yeah, so I think that, obviously the possession, that wouldn't really be a risk, right? Because they'd have to prove that the person possessed it, and if it's just them testing positive. The bigger issue is sort of the latter example that you gave, somebody that comes in on a driving offense and then says that, or somebody that comes in on an assault or something like that, and then it can be evidence that they were under the influence at the time of the incident, which would be evidence that they would otherwise not have. And, I think that there are more HIPAA protections when you're speaking with a medical provider than when you're speaking with a deputy. So those statements can be subpoenaed into court. And so, I don't think that there would be any protections. And what I was going to comment on was sort of in response to Dan's comment. I think that makes sense. The reason that I raised it in this situation, I know it said that the medical staff were screening for withdrawal and then to give medications. And so if if the deputies are screening for withdrawal but can't give any medication or do any other detox protocol, I'm not sure why that screening is existing. It seemed like it had to go through the medical assessment process in order for that to happen in the first place.
So Grant, you just want clarification on like kind of the purpose of that, or the feedback on maybe making sure that that is relevant to the process of actually getting them into the program. Is that kind of
correct?
Okay. Yeah. Okay. Perfect. Okay. We can do that. Captain Eby.
Just want to kind of jump in real quick based on the conversation about the intake screening process. And Grant's correct. I mean, that obviously becomes a question for the courts and the defense as to whether or not certain comments are made. But courts in Oregon have addressed this issue, that there is an obligation and we have the right to ask those type of questions for the purpose of safety and security and classification of individuals entering into the facility. As Dan mentioned, it's quite accurate. Oftentimes the full medical screening, which can take quite a lot of time, many jails don't have staff right there at that door, and so it can be done at a later date. The idea is more of a triage type, as the courts have kind of looked at it, much like an emergency room where you go to the window in an emergency room and you're talking to not a doctor or something, but to get information what's going on so we can determine where to put you. And so in that case, that's oftentimes what facilities have to use just because of the numbers and the staffing levels.
Yeah. Okay. Thank you for that clarification. Again, we'll just kind of provide feedback on the timing of that and where that looks and why they do it, which I think Captain Eby, it's going to be that. But Grant, we'll make sure that we relay some of your concerns to them in terms of feedback with timing of that. Absolutely. Orion.
Oh shoot! I forgot what I forgot what I was going to say. Sorry.
Okay. If you remember, we can always come back for sure. Does anybody
the point that
go ahead.
Correctional facilities are actually HIPAA exempt because sometimes they do have to share things, but they do definitely practice confidentiality. But I think that Captain Eby had a more nuanced statement about what would be used or used against someone.
Okay. Any other comments, questions? I think there's, from what I understood, a consensus of this recommendation going forward. Perfect. Okay. Let's move on to the next one then. Columbia County. This is an example. We did flag, just so you all are aware, we did flag their budget projection sheet initially didn't have any sort of explanations in terms of their requests. We did flag that and ask them to provide explanations. And so the copy that you have in the Google Drive should be the updated one with explanations on their requests. Just so you all are aware of if that was something that you did flag. And so, okay, so their program will be offered to adults in custody who are currently on a MOUD a MOUD program and meet the criteria for continuation of medication treatment. This is an implementation program, and so they are trying to get it off the ground, and their allocated funds were $283,067. And then staff felt that in terms of application requirements with responsiveness, the criteria was met. Their requests were hold on just a second. I'm sorry. Give me one sec. Okay, yes. Sorry, I thought I was on the wrong slide talking about the wrong applicant. I'm not. It's hard sometimes keeping track of all the screens that I'm trying to keep track of. So they do have a prescriber, a nurse, and peer support for their personnel request, along with their supplies, which are UAs and injectables. The total recommendation is 283,014. So any questions, feedback, anything for Columbia County? Dan.
Yeah, I had just one question on budget line 16 where they have a program consultant MD listed at 15% time per month for only $1,600 for that time. And I just wasn't sure if that was a typo essentially, but that's not, it doesn't make sense quite to me. I'm happy that they intend to consult with somebody. And then I was going to also recommend, because they're starting a brand new program and plan to use injectables, that they get TA with OHSU basically.
Okay, so for the injectables, are you talking about for the other one in the personnel category, or the is that what you're referring to?
Yeah, it's
Okay.
Excel line 16. It's in personnel. There's a program consultant
Gotcha.
MD. I mean, I'm
Okay.
glad they didn't spend a ton of money on that because we can also do TA consulting for free for them essentially because we have opioid settlement board funds. But 15% FTE does not come out to $1,600 a month for an MD. So I'm not sure about that.
Okay, we can ask specifically on that to make sure that that makes sense. Grant.
Mine was sort of a feedback comment. I think this is going to come up in a couple others as well, but there seems to be an expansive use of peer support. And again, maybe this is a language issue, but I don't know that a peer should be doing discharge planning. That's not really within that role. And so maybe they're looking for somebody who's qualified to do discharge planning that has lived experience, in which case, great. But I think that they want to be careful about sort of expanding the role of what peers should be used for.
Okay. Grant, do you, just to kind of like close that loop, if this is feedback to maybe be careful about utilizing that, is there kind of feedback on who they should be? Just so that I can maybe provide that as well.
I mean, I would assume it would be a CDAC, but I don't know. I think other professionals on this would probably have a better idea of who would be best suited to sort of do that discharge planning. But yeah, it just, I mean, at least a case manager or somebody who has the qualifications to do that. I think, kind of use the term peer a little broadly sometimes.
Okay, so you're just concerned about maybe it going outside the scope of what a peer support or peer person should actually be doing. Okay.
Correct.
Perfect. Okay. Moxie.
Two things. I would say that the cost of medications for them is really high, both for injectables and also for the tablets for buprenorphine. And then I just calculated at 15% FTE. If you paid most PCPs in internal med or family practice make about $200,000 a year. So at 15% time, that's $30,000 a year. Not that they're going to have to pay that person, but
yeah,
FYI.
Yeah, this is an example of giving them discretion in terms of their local program, their local community. It's something that we can definitely flag for them just to make sure that it is correct. The way that these budget projection sheets work is they calculate according to those numbers. And so it's something that we can definitely flag. But again, it's kind of one of those things where we give them the discretion to come up with their own costs. So, but absolutely, I do have it flagged for sure. Dan.
This is just in response to Grant's comment and protecting kind of the scope of peer work. I guess I would say, like, I went to a JCoin webinar recently about linkage care for jail releases, and I don't feel like there's a national consensus on exactly like one role that should hold the linkage work. And actually, there's like a great variety of people with different credentials in case management, social work, nursing, and people with lived experience and holding peer credentials that do a lot of the work. And depending on which peer agency you'll talk to, some peer agencies will say that their peers absolutely do case management. And maybe it's for a lower census of individuals than someone with higher level credentials, like a social worker in case management. And so I guess I'd feel like it really depends, and it's hard for me to say without knowing a lot more about how they plan to structure things and support the peer that they're talking about.
Yeah, that's great context, Dan, and it's something that we can make sure that they're aware of that context and what it means for that particular position. Mitch?
We actually,
Oh.
sorry.
Sorry.
I would throw out probably maybe the language to provide to them is where they're having discharge planning occurring versus discharge coordination. I think the coordination is totally something that a peer is capable and like a really good person to typically do, especially in an area that maybe like resources are limited or that maybe they are very familiar with them. The planning element is kind of based on medical necessity. And I think I think for a program that's starting up a new service model, like having that described to them clearly is probably a good move.
Perfect. Thank you for that. Orion?
One, love the application, no problem there. I was also thinking, we have in our Office of Recovery and Resilience, we have a forensic peer strategist or coordinator. I forget her exact title, Sharma Lee, and she developed along with a lot of peers a best practices for forensic peers, so people in jails and prisons guide based on sequential intercept model. So at any point during incarceration. So it might be also an opportunity to share with applicants that they want to get some TA on peer use, that I'm sure Sharmali would be really happy to connect with them and talk with them about it.
Perfect. Okay. Thank you for that. I may reach out to you for contact
Yeah, I'll
info.
make an introduction.
Okay, amazing.
Yeah, and I'll send you the guide that she wrote. So that would be something that we can just blast out to,
Okay.
or maybe I'll do
Perfect.
it at the jail commanders.
Perfect. Okay. Any other comments, feedback for Columbia County? Okay. Consensus on a recommendation to move this forward? Perfect. All right. Moving on to Crook County. Just a note as well, we did flag this budget projection sheet. I think initially it was a really low number. The initial request, they had just calculated a month's worth rather than a year's worth. And so we had them correct that and resend it in. And so the copy you have should be a reflection of the entire year's request rather than and I don't know if I updated the, yeah, I did. Okay. It should be the entire year's request rather than just that month. So that was the initial issue with this, but it was fixed. So Crook County's partnered with a local treatment provider to provide eligible adults in custody with treatment services for their opioid use by providing the necessary medication treatment. It is an existing program. We, as staff, felt like they did meet the criteria in terms of responsiveness, and their allocated funds were $257,984. And then their request was in contractual services. A treatment provider, injectables, and test strips were included in that ask. So any questions, feedback for Crook County? Grant.
Yeah, so when they were talking about the eligibility, they said it'll be for clients who are incarcerated for more than 14 days. And I know that's something we've run into here is with pretrial clients, when they're incarcerated, their case is pending and they may have, a trial date or something like that, but they don't have a release date. And so I just wanted to make sure that they essentially considered no release date to also be, more than 14 days. Because originally in Multnomah County, one of the things we ran into, they were only giving MAT to those who had a release date already, which is not a lot of pretrial clients.
Got it. Okay. That is great feedback. Okay. Dan?
I had a comment that I actually thought this was a brand new program based on conversations with the provider a while ago, and then something that says they just established an MOU in September for this program. But I read it like they described how things will work kind of in a present tense, but that it's talking about a new program. That was just my interpretation.
That I could have interpreted that wrong as well. So if you have that information, that's probably more accurate than the way that I read it. So.
And then I had a follow-up question after Grant's comment. So I wholeheartedly agree and would recommend offering MOUD program services much earlier than 14 days in jail stay. I was curious if the 14-day language is referring to some Oregon jail standards, and I felt like I've seen this before, like there's some time period that jails are required to complete a medical screening, maybe 14 days, but that it doesn't always happen on day one.
Okay. Moxie, I see, I see your hands up real quick. Melanie, do you have or Captain Eby, one of you, do you have a response to that comment, particularly the 14-day?
I'll let Melanie respond.
Okay, because you all raised your hands and then you put them down. So.
and Melanie, you're muted.
Yeah, Melanie, you're muted.
Yeah, Melanie, you're muted.
Okay, I clicked the right button this time.
There you go.
So I did read the description to be they don't do their screening until the client has been in the jail for 14 days, which is a very, very common thing in a lot of correctional facilities. I like the idea of recommending it earlier. Maybe they could just clarify at what time they're considering starting the program. And then they have in question 6, they have a description that they have a detox program, I think. So then my next question would be, would they consider transitioning from an opiate detox program into an MAT program?
Got you. Okay.
So.
Okay. Perfect. Thank you for that clarification. Moxie, and then I'll get to Grant.
Yeah, I think they noted in their application that they get people who are traveling through their county throughout the state. And so I just wondered whether they might benefit from some technical assistance to address that issue, because that complicates release plans and how to stabilize people and make sure they're enrolled in Medicaid and that they're covered, and they have supportive services like for housing and things like that, trying to find work, because that could really just exponentially increase the number of agencies that jail interacts with.
Okay, perfect. Thank you for that. Grant?
Yeah, my only other comment that I had in my notes, and I didn't get a chance to re-review the application, and so maybe I missed this, but I didn't see any mention of any behavioral health counseling or other treatment services beyond the medications. And I think that is incredibly important to again, unless this is as was just said, a detox program, still I do think that there should be those, and so that would be the only other feedback I'd have.
Okay, thank you. Any other comments or questions, feedback for Crook County? Perfect. Is there an overall recommendation? So this moves forward. All right. Okay. Curry County. Let me get my stuff pulled up here. Okay. They want to expand their current treatment steps to prescribe and administer a once-a-month injectable, offer telehealth, mood counseling, and SUD treatment, and provide a once-a-month supply of medications upon release. This is an existing program, and the allocated funds for Curry County is $332,389. Staff felt like they met the criteria in terms of responsiveness to questions and the required letters of support. And then their overall ask was for personnel, a medical director, an RN, MAT care nurse. They do have a contractual service ask for a pharmacist, for services from a pharmacist. They did ask for EHR, electronic health records and equipment, and then injectables and supplies. And then a total recommendation of $331,212 and a couple cents there. So any feedback, questions for Curry County? Moxie.
Yes. So I was trying to help a county come up with a plan so that I could be their medical director for their juvenile justice addiction program. And medical directors in this field get sued a lot. And so just because it's a challenging thing to be incarcerated, so the patients don't really want to be there. So it's just contentious. So it was going to cost $25,000 a year for my malpractice insurance to treat 10 patients. And then the lowest quote I could get was $15,000, and that's not even including my hourly rate or salary. So I would just suggest that if CJC wanted to pursue a system to try to get a medical director who could cover all of the jails or cover half of the jails in the state, that would probably help offload the costs a lot, because that's a lot of costs for malpractice insurance per single individual. It's just thousands of dollars. So thanks.
Okay, thank you. Grant?
So again, I think we should approve this application, but one thing that did kind of catch my attention was the 40,000 for the EHR. And because while obviously an EHR helps facilitate MOUD, there's already medical treatment that needs to happen. And so I was curious if this was to like supplement a current EHR, or if they're really kind of using this grant to transition to electronic health records, which I guess just makes me a little more uncomfortable, because it's really just not, it is something that the facility would clearly need to do in order to modernize, and doesn't seem to be directly tied to the MOUD. So I was just curious, I don't know if you have any additional information about the EHR portion.
Yeah, so this was something that I think has been talked about by this group in particular. And so a couple of these requests are not surprising, but this was something that I knew was going to be a discussion among you all in terms of the relevancy of it in relation to this grant. And so that's it. So thank you for bringing that up, just to kind of like anchor this into something, right? It goes back to, and I'm going to try to do this without making everybody dizzy, to this slide, in particular, where the last bullet point, in terms of whether or not something like EHR, to Grant's point, it may not be specific to MOUD. It is an updated thing. There are other counties that did request it. And this discussion is kind of whether or not there's a relevancy to it as it relates to any of these bullet points, particularly the last one. And so that is up to you all in terms of kind of a collaborative discussion and getting a consensus as to whether or not it is applicable. So, Melanie, did you have a comment on this in particular? Sorry.
Not necessarily clarifying question for
Okay.
you, Rachel, and then maybe a comment. You said if they don't use, money out of one section of their budget, they can just roll it into another section, right? Because I
Yeah.
think they underestimated by quite a bit of money in their equipment budget. Because like the lockable refrigerator is about $2,800. You can get them for 2,000, but they're going to store injectables, so they're going to need, a fairly large size refrigerator to do it. The EHR Diamond is a pharmacy that typically offers medications to correctional facilities, and they actually offer a medication administration record with some of their services, which you have to contract with their pharmacy services in order to get it. But I think that if Curry County is looking to implement an EHR system, they should probably look at the actual cost of that. Diamond can probably do a MAR for 40,000, but an actual EHR system, I think that would be quite a bit more than what they have budgeted.
Okay.
That
Okay.
is a Diamond one. I know.
Okay.
I've
That's
been
kind
having
of what I thought,
conversations.
even though it doesn't say that. The cost
Yeah.
made me think it was Diamond.
But we are discussing with DOC potentially purchasing from them, which would be different, so that would change maybe some of the buckets of where that funding is going.
Okay. Dan?
Just on the EHR conversation, I'd have put some thought into this recently, and my experience with providing TA for rural jails is that it would be really, really valuable for them to have for these programs, and it's a pretty significant operational barrier to go without an EHR. And they're frequently, they may frequently have like a part-time general medical care provider, a mental health provider, and then they might be getting a new MOUD provider for these programs. And so they have like 3 different providers. The mental health and the SED provider might not physically come to the jail even, and might do telehealth. And so if the jail has like paper records at the jail, they can't see those records naturally. And it's just a lot of like shuffling, care coordination time, and delays in the coordination. And it's quite difficult for jails. So that's just how I will plan to vote on these, I guess, is to support jails if they're saying we're planning to use the EHR to support the MOUD program, and thinking that actually like 20% of people coming into jail might have opioid use disorder. It's a large percent of the population that has pretty high care coordination needs. So I think it'll be like high value.
Okay. Thank you for that. Moxie?
Can I?
Oh,
Well, I just have a comment to Dan's, if that's
Go
all
ahead.
right, Moxie. I don't mean to jump
No.
in line. Yes, we only have about, well, a little more than half of our jails have EHRs. It's a big issue. DOC is finally coming on board and stepping into whatever era EHRs were. It's a global issue that also impacts MOUD, but I just want to let you guys know that there's going to be 115 million in capacity building funds for the Medicaid waiver, which would also be supporting jails to get EHRs. There's going to be TA individually to jails with the Medicaid waiver that's going to be rolling out after they finish the capacity or the assessments that they just finished that were about at the same time as this. And then I am going to present to the commanders the potential of even just getting a read-only OCHN account that they could have. I mean, OCHN will let them have different instances for all the jails under one account. So at least then they could read in Epic reports from anywhere and kind of get that information. So beyond the
Ryan,
scope of this. But.
I know there's a bunch of hands up, but I just want to make sure the 115 million, would this, as we've talked, bridge that gap to access to those funds?
The capacity building funds are going to be unlocked once the assessments. So also at the same time that this grant went out, an assessment went out to the jails. for
Yeah.
Medicaid waiver. And so that
Yes.
was, once facilities completed that, we're working with CMS. We'll have this money. It's to do a lot of stuff, but I'm sure that EHRs are pretty high priority for
Okay.
that.
I just want to make sure that it's not happening in 2026. Is what
No,
I'm
the
asking.
capacity building funds will be before that.
Okay.
The actual
Okay.
implementation of the waiver isn't till then.
Okay, I just want to make sure that, so that's something to also consider in this discussion is when those funds will cover, potentially cover EHR. It's just something, I just wanted to make that clear as to when those funds are available. So,
It would be
Moxie?
good,
Oh, go ahead.
once we get through all this today, and sorry to talk so much, Rachel, I will actually introduce you to some of our waiver leadership so that you can kind of share globally what came out of this meeting and what we're doing, and so that they can work with you on making sure that we aren't double dipping or duplicating and stuff.
Perfect. Okay. Moxie?
Yes, thanks. Generally, an EHR will speed up coordination of care and also just makes the records legible. So if you're using paper records, there's always people whose handwriting you can't read. If a jail were to request funding for an EHR, but they were only getting, a little bit of bupe tablets and they didn't have a prescriber in mind, that would concern me that they were using it only for the EHR. But given the context of the application, Curry County has requested a substantial amount of funding for injectables, and so I would support that. And also consider advising them that there was another county whose application said that they were both, the jail and the MOUD provider in the community were both using Athena. And so if they happen to know what their clinic is going to be using, that would really help a lot with transition planning and information sharing. To be able to use the same EMR. So I would say go ahead, say you could spend the 40,000. You might want to wait a little bit longer and get Athena or Ocean. Thanks.
Okay, thank you for that. Grant.
Yeah, this is very informative. And actually, I think that, again, very much support the EHR. I think that my concern is one, someone else raised it before, but the amount, frankly, seemed low for an EHR. And, I actually, in my life before becoming an attorney, I worked at Epic. And so I was, quite surprised by how low it was. And what I would hate to see is, with this additional funds being out there, them transition to an EHR. I don't know much about Diamond or what it is, but an EHR that, is very specific on Medicaid or, medication administration, and then have, implementation issues with a larger EHR down the road. And so, I think, again, I guess I see a connection to MOUD, but it does seem like a bigger issue for the jail itself, and especially given the funds that Orion was discussing. I think they should probably reconsider whether that's where they want to spend that 40,000.
Okay. Melanie?
I found something. One, I would like to offer a recommendation, and two, get a clarification.
Okay.
So in question 2, line 4, 5, 4, and 6. So it says that they're going to do a 7-day detox period and then transition to the injectable. So I would recommend some technical assistance on maybe shortening that time period. But number 6, if they're doing an injectable, I would ask for some clarification on what the 1-month supply of medication is. And I'm assuming that their treatment provider is gonna provide the follow-up, because that becomes difficult when you're using injectables, finding providers who are willing to prescribe the injectables and then pharmacies that dispense it. But you can't give or supply the injectable at release. So I would like some clarification on
Okay.
that line.
Okay. We can get that in terms of what that process actually looks like.
Yeah.
So, okay. Okay. Orion?
I think to follow up to Grant's point, yeah, I don't love Diamond Pharmacy, and I feel like they're kind of targeting since Curry County is also one of our counties that doesn't have a health department, because county commissioners have given that up along with Wallowa. I'm in regular conversation with the commander there and trying to help think strategically about some of this stuff. And so our plan is really to think about purchasing from DOC, but I'll share with him kind of concerns, or we can share through the review process. But definitely I agree and worry a little bit about a pharmacy that provides you an electronic health record to get your business type deal thing.
Would this be, because I see that there's kind of a consensus about, not necessarily about not approving EHR in general, but a consensus that there is concern about the cost and the timing. Would it be
I
okay?
would maybe frame my concern would be that everything is within scope, but they should consider consider utility of interoperability with the EHR being specific to MOUD or for all patient needs or something like along that line. Sorry, that was
Yes.
wordy.
No, that's okay. So what I was going to say is can we provide some feedback with the concern about the timing of the other funds that may be available, of approval? It sounds like there's consensus about EHR in general. So approval of funds as is, with the caveat of, providing some feedback to pay attention to the timing of when they engage that EHR. And so what that would do to get it right. And so what that would do would provide them with the opportunity to potentially transfer funds to a different category if they had other opportunities to obtain an EHR at a different time. Is that I saw Grant kind of nodding his head. Is that okay feedback? And just to give them a heads up of, there might be other opportunities for an EHR based on what we know is coming or what's happening simultaneously. We approve the funds as they're requested. You all assume, that you did their homework. This is what their current need is. However, this may be coming. So pay attention to that. And then you can move that 40,000 somewhere else if needed. Is everybody okay with, and I'll be a little bit more eloquent, but the gist of that is, everybody okay with that kind of feedback to, I don't think anybody has a problem with approving it. I think it's just the concerns about the timing and the type and all of that. So if we can provide them with that feedback, is that sufficient to you all?
I'll let Moxie, where she has her hand up, and then it sounds fine to me.
Okay. Moxie?
I would approve their funding as is. My only remaining question is, could they get technical assistance or maybe funding for personnel to help with discharge planning or release planning to California? Because they said something about how they get people who live in California. Could complicate stuff. Thanks.
Yeah.
It does. That's a good point. Maybe we can have OHSU and people that are probably on this committee help, since I'm the health department spokesperson too, to just say, like, maybe we can have some offline technical support for their overall program as they do it and they build it out. And I think that my point was that the jails were somewhat rushed to get these applications submitted. Rachel was amazing to like stand this up in the record time that they did. And then, for anyone that has to deal with contracts, I am immensely sorry for you. So I think there's a lot of this that like jails are like, I don't know what, like, this is who I think I can contract with, but as they get into the weeds and really like executing those, that things might change, right?
Yeah, this is why on our end we allow for a lot of flexibility in terms of what their initial requests are compared to where their money goes. Because we understand it, right? It's real hard to predict future problems or future issues. So Okay, so I'm gonna provide that specific feedback, kind of what we were talking about around the EHR, give them some context, give them, some potential things to look out for. Is there a consensus in terms of funding this as is and then providing some feedback? Perfect. Okay. I just want to note it's 10:14. We've been I know we had a bit of a break. Is everybody okay with continuing, or does anybody need a bit of a break? I'm not sure let me look real quick how far we are.
I could use a short bio break.
Okay, let's do why don't we come back at 10:20? And we can continue to go through these. We're not quite halfway through, but we're getting there. And we'll continue with the conversations. Okay, so 5 minutes.
Rachel, you're amazing.
Thank you for that.
Much appreciated.
Okay, is anybody else back? If you could just go on camera or if I'm talking into the void, that's okay as well. There we go. Perfect. Okay, I think most everybody is back. Orion has his hand up. I'm going to assume that's from previous conversation. So if he has when he gets here, if he has a question, we can answer it. But I think we will move on to the next one if everybody's good with that. Okay, Douglas County. So this program is in collaboration with the treatment provider and will contribute to the maintenance of a safe and more secure facility for adults in custody and staff. It's an existing program, and the allocated funds are $368,288. And their ask is in contractual services. It is a treatment provider. WellPath is the treatment provider that they have identified, and then they do have some admin. So any questions, concerns, feedback for Douglas County? Melanie.
Absolutely nothing to add to this because it's all personnel costs and it all seems appropriate.
Perfect. That's easy. Thank you for that. Moxie?
I'd approve of going ahead and funding it. I put a lot of notes down for you yesterday about the cost of their contracted services. I also felt a little bit concerned about having a 7-day withdrawal management period because some people may leave the jail before 7 days pass. And so I just wondered if some technical assistance may be good for helping to get those people to some kind of therapeutic dose of butte before they leave the jail.
Okay.
Thanks.
Yep. Daniel?
This could be similar to Moxie's comment about in question 5 at the end, there's a comment about AICs that don't qualify for the program, but use opioids on the outside. And so I'm a little bit confused about how they're developing their entry criteria, because to me, if you use opioids on the outside of jail, you would qualify for the MAT program most likely. And maybe I either missed some details or they didn't put details in there, but was from like a TA standpoint, I guess would encourage them to have a program that could serve that population. And I don't know what their particular barriers are to doing that. And then I would be also voting to approve, but I did notice that on the budget, I guess I felt like there was higher nursing time than I've really seen. And I was wondering if it was perhaps so much nursing time that it'll be prohibitive for them to really run the program, because they plan to hire like 4.0 FTE between mostly nursing roles, and that can be really, really challenging for jails. So I just would think it would be a shame if they have this program plan and then it's like they have 3 out of 4 nursing positions open after a year and they can't fill or operate anything. So that was
Okay.
just a concern, but it's reasonable funding. Like the line items are reasonable.
Okay. Okay. Grant?
Yeah, I guess sort of in the same vein as Dan's comment. The staffing levels just seemed high compared to other facilities, and so I wasn't sure if maybe it was sort of supplementing the other medical work they're doing. Again, I do think we should approve this. I think it would be helpful to know, and also with just sort of for full disclosure of everything, medications are just sort of all lumped into a $15,000 ask without really specifying the cost of those. I assume that will come in the more detailed accounting down the road, but
Okay.
just wanted to flag that. Yeah, and I mean, I will also note, I personally had some concerns with WellPath, given their recent run-ins with the law. And so I'm hoping that Douglas County and the other counties that are working with them are just keeping a close eye on their agreements and the care that they are providing.
Okay. Perfect. Thank you for that. Moxie?
Yes, sorry. I was speaking about Grant County when I was talking about the budget items for the amount of pay for salaries for medical staff. Actually, my only concern with budget for this one was the cost of medication per unit. It just wasn't really clear to me exactly what those lines meant in line 34 and 35, labs and meds. That's all,
Okay.
but I would go ahead and approve it. It wouldn't hold me back.
Okay. Yeah, that's to kind of with Grant's point, we can get some clarification on that if we need. Daniel?
I think I had commented on email on this to you, Rachel, earlier, but it
Mhm.
looked like confusing to me about the contract that they supplied with WellPath compared to the CJC budget, where there were FTEs listed that were twice as expensive, basically um, on the WellPath contract, and then I wasn't sure if what the jails may be doing is paying like half of the cost for the whole program. They're paying like half the cost using the CJC grant, and then they're doing another funding source.
Yeah,
Did
so
anyone else? Oh, yeah, go
yeah.
ahead.
Yeah, sorry, I didn't mean to interrupt you. We did have conversation with Douglas County, and they had originally, to your point, had originally uh, essentially done the cost of the entire program, right? And so it was outside of the scope of CJC funds. And we asked them to obviously just use CJC, basically request up to what they were allocated rather than go over in their ask for their estimated cost for the entire program was over the allocated funds. I think that is a little bit more clear. And so that's where that kind of difference comes from is their initial ask was for the entire cost of the program, whereas there was only a very specific amount that was allocated to them from CJC. And so for the rest of the cost, that's something that Douglas County is going to have to figure out where the rest of that's coming from, to your point. So
Okay.
yes, so we did flag that. We did kind of have that conversation of you only have this much allocation. If you request more, it's going to be problematic in terms of reductions that we're going to have to make. And so just make it specific to what you were allocated to CJC. Does that
So
make sense?
Yeah, just to let everyone on the committee know, I'm looking at the Douglas contract document that has WellPath information about staffing. And so the actual cost of the staffing that we looked at is like 600,000.
Yes.
What seems kind of like a miscommunication to me though is that we're seeing the full FTE on the CJC budget, but then
Mhm.
we know that actually it's only paying for half of that. So shouldn't they adjust the
Yeah.
FTEs down on the
Yes,
CJC budget?
yes. And that's probably my fault. I don't know that in my communication I was clear that to make that adjustment in the actual projection sheet. I just made it clear that the allocation from CJC was this specific and specific amount of funds, and so they had to request up to that, if that makes sense. So that might have been my fault, Dan, in not providing that much detail and asking them to fix it. But we can do that as we go forward for reporting. We'll make sure that that is taken care of. So does that like
Yeah,
address your
that helps.
concern?
I just want
Okay.
to make sure that this committee understands that it's definitely a lot of money that they think they need to staff the program, especially nursing. I mean, it seems high to me, quite high with the like total, given that the total context is it's like a $630,000 program for these FTEs primarily.
Yeah. So yeah, we address that on our end, but we can definitely address the FTEs, and that's my fault for not following up with them. So, Mitch.
Yeah, I think kind of similar to Dan, I'm looking at that contract agreement, and I would actually just throw this towards the medically minded staff here, but it seems as though they're already operating healthcare services, but are saying that this MAT addition is going to be like need the 4 additional staff, and I'm just kind of, I guess, like in my mind, confused why this wouldn't be braided into their existing medical services if that's what's happening. Like that seems like a weird siloing effect that we would be contributing to.
Orion?
I could offer some. I haven't looked at, I should look at this one. Douglas's WellPath, we have a lot of these for-profit contractors and different jails throughout the state, and some have great programs, some do not. I would say, I think we have some with a different contractor here in the room that have a really outstanding program. It all comes down to how the contract is written and the negotiation that happens into that. And so if they're adding MOUD that wasn't there before, then WellPath is pushing back and saying that's not in the scope. It comes down to like, okay, well, we're going to fund this piece, adding that. And so they might be doing some discounted thing that talks to, I think what you guys were saying, that it's not enough money. If they've had conversations with their existing health service contractor. And then, it always comes down to a negotiation when that contract needs renewed about what the jail wants to have, what the county commissioners are giving the jail as far as funding, and if they have to open it back up for another RFP for other contractors to do that. And it's my opinion that WellPath has been kind of moving out of the state from some other facilities, but
Just to provide, and Grant, I see your hands up, but just to provide some context from a CJC standpoint, we don't have anything to do with subawardees of funding. Like the process for counties is their process, just because there is no way we could track that. It's so different. And so for us, we just want to make sure, like we have very specific qualifications that are outlined in the grant agreement that they have to follow as it pertains to subawardees. But the cost and where the money goes and the contract between the county or the applicant and their treatment provider or anybody that they're going to have a subaward with, we are not part of that process. And so if there's specific feedback to that, I'm happy to pass it along. But in terms of process and cost, it's outside the scope of what CJC does. In terms of our process and tracking that. So, Grant?
Yeah, I mean, can we give them feedback that maybe their county council should look at renegotiating this contract or engaging in it? Because I mean, I guess the only last thing to say to this is that the addition of the MAT program is essentially adding a third of the cost to their overall medical care, which is pretty astonishing. I mean, that's a fairly significant increase, especially given the size of the facility. So,
Okay.
yeah, I mean, that's for Douglas County to figure out, but it does seem like, yeah, some predatory business dealings, but
Yeah, no, we can definitely let them know. And like I said, there is a process that they do have to follow that's outlined in the grant agreement. So we can also direct them to that language as well. So for sure. Moxie?
Just because we talked a little bit about one of the vendors, I wanted to just add that if anyone knows a jail that has NAF care, there is a doctor in Arizona that runs an OTP within NAF care. And so NAF care already has that skill set available. They could probably scale that up. I believe maybe Washington County has NAF care and one other. Thanks.
Okay, thank you. Okay, any other questions, feedback? It sounds as though there is a consensus to move this forward at the recommended funding with some feedback attached. Okay. Perfect. Okay, Grant County. Give me one sec. Pull up my stuff over here. Okay, so So Grant County program is going to be offered as part of the intake process for all adults in custody, and the treatment provider will provide mood care weekly to ensure adequate adult in custody access to treatment. This is an implementation program. The allocated funds $339,799, and staff felt as though all criteria was met in terms of responsiveness to the application questions. Their ask is in contractual services as well. CADC, nurse practitioner, program supervisor, and medication is part of the contractual ask, along with some admin. Any feedback or questions for Grant County? Moxie.
I think that overall it looked good. I think that their salaries for their medical people are pretty high. I did think that I think they have a potential delay to treating people. So they might work with technical assistants to try to give people buprenorphine when their COWS score hits 8 or more, instead of waiting for a certain amount of time. Just because of that, how sometimes jails release people in the night or on a weekend, and they might not have them in as long as they expected to. And it's just a missed window of opportunity if we have some delays there. So I put that all in the document I sent you yesterday with some more detail. Thanks.
Perfect. Thank you. Grant, did you have your hand up? Nope. Okay. Any other comments or questions about Grant County? Okay. Is there a recommendation to move this one forward then?
I would
Perfect.
recommend that we move it forward.
Perfect. Thank you, Captain Eby. All right. Okay, Jackson County. Secure funding for assessment and medications for opioid use, and they also want to ensure the necessary treatment and support for adults in custody. This is an existing program. Allocated funds was $428,280. Staff felt that all of the criteria was met in terms of responsiveness to the application and the requirements. Dan, you have your hand up. Is this a conflict for you?
No, not a conflict.
Oh, okay.
Just I believe this is a brand new program. They have had intents and desires to establish MAT program for a long time. But I believe engaging the OTP is coming soon, basically, but not yet.
Oh, okay. Thank you for that then.
Actually, I have some updated. So this is Jackson. They've had the OTP has been taking care. The one they have 2 OTPs in Jackson County. One has been working to take care of their patients over time, and they have also been guest dosing the other OTP's patients at no charge. So the addition here is that they would do new starts with that.
Yeah. So in question 3, they do say they have an existing partnership with an OTP, which is where I got the existing program.
Yeah, sorry. I was forgetting that this is like a huge expansion for them, and I don't tend to think about like that they had much of really a program, but they could continue some people with guest dosing. Yep. So thank you for that. That's right. That question does spell out more of the detail there.
Yeah. Okay. No, if I'm wrong, that's probably predictable and okay. I just wanted to make sure that you all got the right information. So, any Moxie?
I couldn't tell reading their budget, and maybe it's been revised. I couldn't tell how much the medications cost and versus how much they were going to be spending on personnel and patient, like other logistical issues.
Are you talking about in this specific contractual section? Is that okay?
I believe so. I can pull it up.
No, it's okay. I think that's all they just didn't specify what's going what's going to personnel versus what's going to medication. Is that what you're asking? Okay, we'll make sure on our end that we capture that on the back end of reporting. So, Grant?
Yeah, I guess I have somewhat of a question. I mean, that I think what Moxie just said about the basically 170,000, it would be kind of good to know where that was going, but hoping that will come out in the detailed invoicing. The peers, again, I think it's great to engage peers. I was a little confused how they were going to be used in this program. It says the peers will help guide the client through the treatment process. And so I guess I wasn't fully understanding, are the peers going to be supplementing an existing treatment program that is going, are the peers coming into the facility? And maybe I missed it because I'm going off my notes here, but I couldn't really understand the peer contracts, and I'm fully supportive of them. I think that it's correct, and establishing those relationships is important and a good idea. I guess I couldn't understand sort of how they played into the MOUD.
The overall program, like what their role is actually going to be. Okay. Okay. Moxie?
Yeah, sorry, I just found my own notes that were from their separate document. I didn't see such a document from other counties, and that's great that they did provide it. It was about medications for OUD. They said that they would break it down to methadone charges would be a charge of $12.50 per day, which is the going rate for daily dosing for methadone. So if you're in the community and you charge Medicaid, you charge about $12.50 a day to have a patient come into your clinic. I just wondered if over time it might make sense for them just to open their own dosing window, because the reason that methadone is valuable in the community is that it's maximum security. But when you're already in a jail setting, you already have so much security that having a program come in and charge you that money for highly secure services, to me, doesn't make as much sense as just operating your own window, if that is helpful. Just for them to plan over 5 to 10 years, could they think about opening their own? Thanks.
Okay, thank you. I think Orion is next.
I was just going to share, just for the group, that Brian Mann, the health officer for Jackson County, comes from addiction medicine and behavioral health, and so is here as a visitor in the meeting and is working very closely with Jackson County Jail on the implementation and putting a lot of thought into this in the partnership. So certainly helpful, but just so that you guys know, I think they have some really great support locally there with the provider who knows the business, but is now wearing the hat of the health agency as well, and just working alongside the jail.
Thank you for that. Mitch?
This is kind of both to answer a question, but also to maybe raise another one. So in that MOUD document, they do specify that the peers are going to be contracted through 3 separate agencies, just so they can give choice to those providers. So I'm assuming that's probably why they're staffing 3 peers specifically. However, the kind of issue that I would raise is just to ensure that none of them, assuming that those clients stay with MTC moving forward, that there's going to be any problem with the dual service authorization, or they're at least getting technical assistance to ensure that those are being filed ahead of time.
Okay, thank you for that. Any other comments, questions on Jackson County? Sounds like there's consensus to move this application forward as is. Perfect. All right. Okay, Lane County. Pull my stuff up here. Okay, so their proposal overview is individuals are screened at the time of booking, participation in additional screening by staff, and then is scheduled to see a provider to receive treatment. That's kind of the way that they outlined it in one of their answers. This is an existing program. The allocated funds 404,555. Staff felt like they did meet the criteria of responsiveness of what was required. Their contractual services, they do have some equipment for secure storage, and then their supplies is where the majority of their request comes from, with medication as well as secure medication storage. Any questions or comments, feedback for Lane County?
I think it's for the most part, pretty straightforward the way they put it in there, and I would support pushing it forward.
Perfect. Okay, any other comments? The fastest one, not that I want to jinx it, but this is the fastest one we've gone through. Probably shouldn't have said that. Okay. Lane County then, there's a consensus to move forward with it as is. Perfect. Lincoln County. Their proposal overview is that their assessed AICs are assessed and provided counseling services as well as the appropriate medication. A treatment plan is also established for when the AIC is released from custody. This is an existing program. Allocated funds was $351,532. Staff felt like they did meet the criteria in terms of responsiveness to the questions and the required letters of commitment. Their request is contractual services with a treatment provider. They do identify their treatment provider, and then their big request is supplies, which is medications. So any comments or questions on Lincoln County? Moxie.
I was just thinking because of the number of people who are traveling through Lincoln County in the probably summer. They said they get a lot of travelers. If they might need some technical assistance or staffing, they might benefit from that. If they end up having to redirect their funds anywhere across the services that we approve, I don't see any issue with approving their program as it is for now.
Okay, thank you. Melanie?
I was trying to scroll through real quick and see if I could just answer my own question. I think they're using Sublocade already. Based on the comments, I was only going to make a comment since all of their budget was for their provider and for the medication. I didn't see anything for storage, so they may need to consider like where they're going to store the Sublocade in their budget, but that's the only thing.
Okay. I think your answer is maybe in question 4, if I'm reading that first paragraph correctly in the right context. I don't know if that's what I'm doing, but I think they are using it is the way I'm reading it.
That's kind of what I'm thinking too. So never mind.
Okay. I can also just note that just to make sure like it was a concern since you are using it, safe storage. We can absolutely just put that in there for sure. So, any other comments or questions about Lincoln County?
I'll just comment that if they wanted to, they could run a more rapid protocol to start people on Sublocade faster than 7 days. And we could talk to them about that if they want TA on that.
Okay.
But they stated they want to increase access to their program. So that could be pretty helpful if they are thinking about people who only stay 7 days or they only stay 5 days or whatever. You could start the medication probably in 4 days or less. So
okay, perfect. Thank you for that. Any other comments for
I would support moving it forward.
All right, thank you. All the other consents? Oh, Moxie, you have a comment?
Yeah, sorry. I just wanted to suggest that they could get in touch with Good Samaritan because they're expanding their services in addiction in Newport. So that might make a great partner for them. Thanks.
Okay. All right, Grant?
Sorry, I
Okay.
had somebody stop into my office, and so I apologize if this was already raised or if it wasn't. But when I read this, it seemed like it's a process where somebody has to essentially initiate it. They said, where an individual requests the medications, they're offered an appointment with a provider. It didn't seem like it was screening based, and I think that having a screening would make more sense than relying on ASCs to sort of initiate the process.
Okay. Perfect. Okay, we got like halfway through a consensus, so I'll just ask again. Captain Eby said moving this forward. Is everybody else okay with the feedback and the, okay? Perfect. Moving on then. We have Malheur County. Their proposal overview is to expand screening at jail entry and enroll patients with opioid use disorder to be able to start treatment while in custody. They do have an existing program, and then their allocated funds were $337,258. They did meet the criteria for responsiveness. Staff felt like they did, along with their letters of commitment. Just a note, this wasn't updated, very small, just adjustment. This was an updated budget projection sheet provided to you all. We do have a cap for admin ask, and they asked for a little bit past that cap. And so we had to adjust the admin ask and then take those funds and put them somewhere else. So the total's the same, but the math was a little bit off, and so we had to increase and decrease some of these categories. So just a note, it is a new one, just in case you did big notes on the older version. So they have a small ask in contractual services, as well as equipment storage for medication, but the majority of their ask is for medication. So any comments, questions, feedback for Malheur County? Orion, was that a thumbs up, or Captain Eby gave a thumbs up? I think Orion as well.
I feel like it was in scope. I don't know if there are comments, Moxie, but I think that I would move to approve or support this.
Okay.
proposal.
Moxie?
Yeah, I thought the application was great and I would love to approve it. I did wonder whether their medication was bupe with naloxone or bupe monoproduct. Bupe monoproduct is substantially less expensive, so it just might help them stretch their budget.
Okay. We can provide that feedback. Okay, sounds as though you all are good to move forward with this. Perfect. All right. Next one is Marion County. Also just wanted to give kudos to this applicant. Their answers and their letters of commitment were also very thorough, did a great job with this as well. So just wanted to throw that out there and recognize this applicant. So their proposal overview is the increase access to medication access, facilitate additional transitional planning, and reduce existing barriers to providing treatment services. This is an existing program. Allocated funds 457, sorry. And then staff felt like they met all of the criteria for responsiveness. They do have a request for personnel, contractual services as well, and then with the majority of their ask being in supplies, medication, storage and supply cabinets, and then UAs as well. So any questions, feedback, clarification needed for Marion County?
I just want to reiterate, I thought it was a really well put together application. There was a lot of thoroughness, and obviously they have an existing program, so they kind of are building off of that. But just for the question of moving forward, I would support it at this time.
Perfect. Thank you. Moxie?
Yeah, thanks. I had written down that the price they listed, it was, I think, line 88 in their budget, was $430 for medication per unit. And they mentioned buprenorphine injections. If they're paying $430 per injection, can they teach everyone else how to do that too? Because that's really low. But also it could be a typo, in which case they might, you can let them spend more money on those if you need to. But I just thought that was great. And I wondered if they could serve as a model for tracking people and also for the collaboration between like the stabilization center and there were other agencies. I just thought it was really great application.
Yeah, absolutely. Yeah, I can get more detail on the medication if that's something that I think would that you all think would be helpful for other potential applicants as well. I think Daniel is next.
This I like this application as well. On the topic of the $430 extended release buprenorphine, I believe that is weekly Brixadi that they're talking about, because they on that line item talk about the injections being for AICs who get weekly dosing. So that would be the price of the Brixadi product, pretty much, the weekly Brixadi. And then I had like a clarification question, I guess, about the stabilization center, and I'm excited about their plans to serve that center. And then I think I had heard from CJC that community correction centers were not like eligible. And how is this different, I guess, than a community correction center, and maybe just helping me understand about that?
Yeah, so that's a great question. So this is something that there's one similar to another application that's coming up that has a similar kind of issue in terms of where the funds are used. We will make very clear to them that funds are to be used within the correctional facility. And so this is what their process is, but we'll make sure to clarify that in terms of where these funds are to be used, and to make sure that it is helping their process, but also staying within line of this particular grant program. So this is something that we flagged as well for feedback to them, to make sure that it's in line with the grant, the spirit of the grant, and where they can use their funds. So absolutely.
Is it like part of the stabilization center is a local correctional facility? Is that what you mean?
Yeah. So from what I understand, I could be wrong. Let me actually check before I speak. Go ahead, Mitch, if you have something that you wanted to say while I look this
Yeah,
up.
just a really quick comment, and I would say like cautionary thing is I noticed that they said the MET program would be available to them by consult 7 days a week, which I think is really, really awesome. I think just in kind of specifying the time frame, because that'll be really good for the informed consent with the clients as well, just to know like how quickly they can get some sort of consultation with their providers.
Okay, thank you. Orion?
I guess mine's a little bit more just clarification on the discussion that you and Dr. Hoover were having. This has also been coming up in waiver world about what some of the transition centers are classified as, like the Washington meets
Mhm.
all of the classification and operates as a correctional facility, yet people go in and out from there. I think we're also, I mean, I know we're trying to stay in line of the scope and the grant and what was reached, but we're also kind of talking about windows of time here where people are in the jail over to the transition center and then back out, or in a deflection center instead of showing up at the jail. Is there opportunity for CJC and Representative Marsh to kind of examine that so that we're clear with jails about where, even though the services and funding are being provided to the jail itself, can they meet patients that are across the street in the transition center, or like the certain, because I worry that we're also creating a lack of continuity if we're trying to get people started. They're only in the jail for 24 hours and then they're kicked over to the in-house transition center. So I think I'm just kind of raising a concern about how we're thinking about that, or like as these deflection centers stand up, instead of going to the jail, someone goes to the deflection center, so they're not going to get treated where they would get treated if they went to the jail.
Yeah.
But I know we're also getting into the legality and the legislation pieces. So
Yeah, so currently as it stands, the correctional facility, the way that it's defined in the bill, it is a local correctional facility with the definition that it has in the bill. It is very specific to jails. I know that there has been outside conversation about what you're referring to in terms of community corrections and how that how OHP and their definition, OHP provides specific stuff to things that are outside the definition of this bill. So yes, that is a conversation that is outside of the scope of this meeting. So as it currently stands, no. But to go back to Dan, no, in terms of like your example of like Washington County and the community corrections doesn't fall under the definition of the correctional facility as it's defined in this grant. Potential to change, absolutely recognize that it could expand services to people. To Dan's question though, in the way that I read this, Dan, and maybe this is a point for clarification or feedback that we can get from them. If you look at question 2, it's not a transition center anymore. So it used to be an in-house transition center. It is now a stabilization center. The way that I read this is that it is still in-house. And I could be wrong in the way that this was interpreted by staff. And it's like the second paragraph. They did have a transitional center that was in-house. They are turning that into a stabilization center. If the feedback is that we get more detail on what that actually means, and if it is no longer in-house, then we can then direct them that funds are only specific to the correctional facility, if that makes sense. But that is not the way that I read this, just in knowing the context of the transitional center versus the stabilization center. And if you all disagree with me, that is perfectly okay.
Yeah, I don't know enough about the way their facilities work there. I
Okay.
like the stated uses for medication, I guess, as long as it's allowable.
Okay. So
Basically.
that's something. Oh, yeah, absolutely. That's something that we can get clarification on. That's how we read it. But we'll make sure that your concern is addressed and met just in feedback and where these funds are actually going. So is that sufficient for what you were talking about?
Yeah. Yep.
Okay. Perfect. Okay. Moxie?
Yes, my question is about their oral fluid drug testing. So I am not thinking, so if somebody gets released from a jail and they're getting stabilized, but they're out in the community, the oral testing might be good enough, but oral testing is not as reliable as urine testing. And there's limitations to it. So one limitation is it doesn't detect drugs for as long as a urine test would. So it makes me wonder if how they use oral testing in general, like in their jail, if they're using oral testing, they might be under diagnosing OUD. They might not be identifying every case of OUD, and they might not be treating all the people that they could while they're incarcerated. If they do oral testing, it's convenient, it's private. You don't have to go in the bathroom and watch someone use the toilet and all that. But it does miss some people, most likely.
Okay. So just some feedback on maybe their process of testing and whether or not they can improve that. Okay. Any other comments, questions about Marion County? feedback, concerns? Okay. Looks as though there's consensus to move this forward. Is that okay? Perfect. Okay. Multnomah County. This is an existing program. The proposal overview is to operationalize pre-dose methadone dispensing and make capital improvements in preparation for regulatory approval of methadone storage in both jails. This is the only application where it is addressing a need for 2 jails within this county. So that is something just to note. And their allocated funds were $663,910. Staff felt like they did meet the criteria for responsiveness as well as the letters of commitment that were required. Their personnel ask was for medical deputy, RN treatment coordinator and a project manager. Contractual services, they do note in there, I did put specific positions in there. Those are not yet filled. I just put them kind of on here so you would understand part of the request, as well as medication. They do have, as they note in their proposal overview, they do have some facility requests for room modifications, where they do provide some detail of that, and some equipment that would be required for those facilities, that modification, as well as supplies for medication and safe storage. So though and this ask is for both jails. Just to kind of clarify that. So any comments, questions, feedback for Multnomah County's application? One thing they do note as well with contractual services is they are going through their process of identifying a treatment provider. And so they did not identify one, which is why I noted those positions. Part of that request is after they go through their procurement process of getting a treatment provider, but their intention is that they will have one. Grant.
Yeah, I'd say to approve this one, though I will say really 2 things that kind of caught my attention. Well, 3 things actually. The first is they talked about limited eligibility for methadone initiation, and but didn't really specify what that eligibility would be, or tie it to like medical eligibility. And then later on, they talked about 15 patients per month for methadone. I just wish, knowing the population of this jail and the need of this jail, I really would have liked to have seen that be significantly higher. And I'm guessing that's the limited eligibility. I'd just be curious what the actual eligibility criteria would be with that.
Okay.
And then the final thing, and I've sort of fallen off of this, but there have been a couple other applications that have come through where I meant to mention it, but and the actual counseling and treatment services outside of the medication administration. I'm hoping that's what the treatment coordinator will somewhat do, but it's something that I feel like is lacking at the facilities here, especially the detention center downtown. And yeah, I'm concerned about MOUD programs starting and being in facilities without having those additional support services.
Okay. Okay. And for your initial one, feedback on I just want to make sure this is clear. Feedback on kind of the eligibility as it relates to their capacity. Is that kind of what that linkage between the 15, is that their capacity because of their process, or like is their process hindering?
Yeah, so
okay. Okay.
Exactly. So it looks
Okay.
like the meds they have are for 15 patients per month. So they're setting their capacity budgetarily with that, which how much methadone they're getting. But then earlier it says that there would be limited eligibility for methadone initiation.
Perfect.
And I was
Okay.
curious what criteria they were using to select those spots.
Got you. Okay. Perfect. And then note on the support services beyond just medication. So, okay. Thank you for that. Orion?
I would just say I've been working with Multnomah a lot. We had meetings with John McElvey in Minnesota and trying to stand up a lot of their expansion before this grant opportunity came out. They're one of the only jails that I know that have and I shouldn't say that because maybe I just am not aware, but they have a whole transition service team for Multnomah that do all the transitioning, and that is who is providing MOUD treatment across all their facilities. So they have a really good system for some of the continuity pieces. I think that you were touching on, Grant, and then they also have a pretty great probation and parole team that they send them over to with a lot of other like wraparound supports, housing, and other needs after they're leaving. But just so that you guys are aware that they've been doing that, and so I know that there's a really high need there. I think they say they have like there's probably like 300 people that are in need of SUD, and they're really trying to work to expand services to reach more people. So I don't know I haven't looked in detail at the budget, but I'll look at what you mentioned about not very many methadone doses.
Okay. Thank you for that context. Mitch?
Swear one of these days I'll remember where the mute button is. So just kind of two things. One, I just think given how many methadone MAT providers exist in the Portland area, I'm a little concerned. I didn't see anything in here about how patient choice will be a factor or kind of referral to any of those other providers will be a factor. I'm just saying that because some of the smaller jails did mention this as kind of a point of their proposal. The other thing, again, like I think that 15 dose is really a low estimate, and then I'm just a little confused why they're budgeting like an RN at 0.6 FTE for the 15 patients. Like again, those numbers kind of don't match up for my head.
Okay. Okay. It's definitely something that we can get clarification on it and provide feedback for, kind of that linkage of the request, overall request. Moxie?
Yes, thanks. I think this application and the issue that Grant brought up with treating a low number of patients, it just, I think, highlights the importance of making sure that people aren't overspending on clinician care, that we're not spending like hundreds of thousands of dollars a year to treat 15 people a month, just because that's the kind of salary that you'd expect in medicine for, like 200,000 a year or something would be if you treat 20 people per day in a clinic. So we just, keeping that in mind, 15 people per month versus 20 people a day, that's a big discrepancy. So I think as far as like wise use of taxpayer funds and everything, and public health benefit, I think it wouldn't hold me up in approving the application, but it's just useful for the CJC to know.
Okay. Thank you. Grant, I think you're next.
Yeah, I just wanted to respond briefly to Orion's thoughts. I practice here in Multnomah County, and I think that there is hope for those transition services. I don't think that those actually exist in a meaningful way, nor do, frankly, the services in the DCJ or at the probation department. So, I do think that this is an issue that Multnomah County is dealing with, and part of it has to do with staffing issues. But I think that I would sort of agree with what Moxie just said as well, is that I was frankly surprised by the personnel budget as compared to the number of folks that they're seeking to provide methadone to. And I'm hoping that some of this is to sort of supplement the existing MAT program they have, and not just dedicated to this methadone expansion.
Okay, thank you for that. Melanie?
Sorry, I just want to point out that in their application, they state they don't currently provide methadone. This is to offer an expansion to their services. So I would assume that they don't actually have the right numbers to plug into how many people they're going to have. I think it was very courageous of Multnomah County to pick up a project like this. And I love the fact that they included both of their jails, because they are the only county in Oregon that has 2 jails that they manage, and they have a significant SUD population. And so I really just wanted to point that out for the committee, because I think we're getting lost in those numbers for this application. But it says very clearly they don't have this service. They are trying to get it set up. So I assume, one, they don't actually know what staffing is going to look like, what the numbers of the people on methadone. It does say that this is a phased project, that the first phase is continuing people who have existing prescriptions, which if they don't do currently, then it makes it difficult to, estimate what are the numbers of those people moving forward. So I just want to make sure we keep that in mind.
So Melanie, thank you for that. And with that context and everybody's concern around this, can the feedback be like, we recognize that these may be an estimate, we're not, you all may not know numbers. Is it something that that we can provide some feedback to continue to monitor and make adjustments as appropriate, right? And so if there's some concern about personnel or concern about in the FTE and contractual, is this something that we can just say, we recognize this is a program that is starting. We recognize that this is something you may not have good information about numbers. Is it something that you all can monitor as you go through? I saw a thumbs up. Is this okay? Okay, perfect. Thank you for that context, Melanie. I think that will help with the feedback and making it a little bit more workable for them. So, Orion?
Mine was really following up with really similar to what Melanie shared. When we did have the meeting with SOTA, there was not good data on number of people that were on methadone, but there was a desire to add that. There's also been conversations with them and DOC about injectables. They do have a budget and they're trying to reach a lot of people, and hopefully that this would be judiciously spent to try and do that. And so I would, urge them to try to think about exact numbers. If this is only, if all that they're asking for in this portion of the budget is really that methadone piece, because they have to put out an RFP because of county rules.
Yep. Yeah. So, okay. Consensus to move this forward with some feedback and some context there. Perfect. Okay. Just want to note we've been for about an hour since our last break. We have 6 left, 6 applications left. And I also would like to have a short discussion afterwards, just on supplemental stuff, get some input on that. Is it appropriate for another break right now, and then we can just finish applications and finish discussion? Or do you all want to continue? I just want to do a check right now because we're about an hour since our last break. We're also 3.5 hours into this meeting, so I know we're almost there. Is a break appropriate at this time?
I wouldn't
I
mind
vote for a
break.
break and then
Okay.
come back and finish it out.
Perfect. Okay, why don't we do a 10-minute break? We'll come back at 11:30 and then we will finish up the applications and then have that conversation. And then we should be good. So cool. Okay. See you at 11:30. Okay, do we have some people back? All right, looks like it. Okay. So I think most everybody is back. Orion also has his hand up. I'm going to assume that was from the last discussion. But we will move forward. So Norcor, they just kind of as some context, they serve Wasco, Hood River, Sherman, and Gilliam counties. Their MOUD program is designed to provide a comprehensive structural approach to support individuals in custody. It is an existing program. Their allocated funds were 338,256. Again, staff felt like they met the criteria for responsiveness. Their overall ask, they do have some personnel, which behavioral health specialists, nurses, they do request a few nurses, medical clinician and assistant, a peer support specialist and contractual services. They did ask for a vehicle and equipment. There were other applicants that did ask for a vehicle. This is an allowable expense from CJC, so we did kind of vet that and ask some questions and got some clarification on that. So, and then supplies is for medications. So, any questions, feedback, clarification needed for Norcor? Also, just wanted to note as I'm thinking about the flags for this, they do in their application mention juveniles. We did flag that. It is part of their kind of campus. I don't know if that's the right word. Their facilities, they do have a juvenile facility. The feedback that they will receive is that these funds can only go to adults in custody. And so, and just in case you all did notice that in their application, we will address that with the applicant as well. So, Dan, I think you have your hand up.
Whoops, I'm not, well, I may have tried to ask about the juvenile thing, but you just clarified that.
Okay.
Yeah.
Okay, cool. Moxie?
I am just curious about where I can learn more about the barriers for youth because there's so much need. And we come up against this in methadone clinics and in jails and everywhere. So I'm just wondering what we can do about that.
Yeah, that's a great question. We did look at again, we have to rely on kind of definitions within the bill and definitions and within the OARs and did determine that at this time it is just meant for adults in custody. But yes, that's something I think that is a conversation that can happen that needs to happen outside of the context of this meeting for sure. Moxie?
Yes, thanks. This came up with several applications, but I didn't want to bring it up at the time on another one. Some programs are offering both buprenorphine and naltrexone, and I just get concerned when I see naltrexone on offer because it's not really recommended for moderate or severe opioid use disorder. So I just would love to know, in terms of quality across the state, when is it being offered and to whom? And are they giving oral naltrexone, which isn't really evidence-based at all? If the patient uses occasional fentanyl but has alcohol use disorder, then injectable naltrexone would be really great, maybe. But that's just a major concern to me when people use naltrexone. Make sure that patients know that it's substandard.
Okay, we can give that feedback. Or Melanie, you had your hand up. Are you good? Okay. Orion?
Just a comment that's not really in the scope of this, but I think I mentioned the issue of juvenile need in the meetings with Representative Dexter, but I don't recall And Moxie, if you want to connect offline, if you don't know, Bernardito already with OHA is over our youth treatment, and can kind of connect you so that you guys could brainstorm and think about that.
Okay. Any other comments, questions, feedback for Norcor? All right. Oh, Moxie, go ahead.
Sorry, my only thing with these EHR requests is that I wonder when I see a low budget for EHR, and I don't know if their budget was sufficient. Does that include technical support and onboarding training for new employees and things like that? Because EHRs can be great, but if there's a problem with it and it doesn't work, it's like having a notebook that's glued together. You just can't do anything at all. So I just wanted to make sure that jails all know that when they buy this, it should include a lot of help permanently. So
Like the training okay, we can make sure that that's something that they're aware of, that it's available. Thank you for that. Okay. Springfield, this was our only city applicant, city jail correctional facility applicant. They want to provide a low barrier access point to stabilize patients and coordinate their treatment and recovery upon release from custody. This is an implementation program, and their allocated funds were $114,769. Again, met the criteria in terms of responsiveness and the commitment letters. And then their ask is contractual services with treatment provider services and medications. So any comments, clarification needed, feedback for Springfield? Dan.
So I had a concern about a best practice where in their question 2 response, they said they would have a referral to a court and peer navigator. And then if the individual is interested in MAT, the court will contact a peer navigator to arrange a consultation. And I think they really need a recommendation that that's not appropriate, that basically someone's request for MAT goes to a peer to assess them. It says then the peer will meet to discuss MAT options and conduct a treatment intake assessment. So that's not appropriate scope for a peer, and they would need to have a medical professional do that.
Okay, you're talking about number 2 specifically, right? In the
It's it's
okay.
in question
Point,
2.
Question
response,
2.2. Okay.
Point 2 and 3. Yep.
Okay. Okay. So just feedback on making sure that the scope of the peer navigator does not include the assessment process. Is that what you're getting at? Okay.
Yep,
Perfect.
exactly. They should have a medical provider assess for respond to interest in MAT and decide candidacy and counseling for people.
Okay. Okay. We can provide that. Grant?
Yeah, I had that similar feedback, and also with regards to referring it to the court. There is no reason why the court should be notified about someone's decision to engage in MAT. And so I have a big issue with that one. It is one thing if the person is in treatment court, but the entry into treatment court is sort of the last thing they comment on there. And so, I would want them to know that that information just should not be provided.
Okay. Okay, we can give that feedback in response to the. I just want to make sure that process wise, this could be more clear for them, because I also did see 0.6 on there with the entry to treatment court. I'm trying to think. I don't know if there's a linkage to that. If is what I kind of took from it, right? And so, are you saying that they're what am I trying to say here? Basically, they should not be notifying the court regardless of their process of how people get into treatment court. Like there should not be a link between the two.
Yes. Well, so I mean, I think the
Okay.
thing is that, what is eligible for treatment court is generally fairly narrow field. And
Right.
so they're saying that they're going to notify the court, it sounds like, for anybody who is
Okay.
entering their MAT program. And that's
Okay.
concerning. If someone is in a treatment court and wants to sign an ROI so that the court can learn about their engagement in MAT while they're in custody, that's one thing.
Okay.
But the way that they end it with entry into treatment court makes me feel like this is all occurring pre-trial, and
Mhm.
that's very concerning.
Okay, thank you for being way more eloquent. That's what I want. I just wanted to make sure that that was what you were, that was what your concern was, that it was all, the process was before. And we can definitely provide that feedback for sure. Moxie?
I was thinking that maybe with the peer, if the peer were involved at the court, they might just require everyone who's in custody to meet with the peer briefly. And then that peer just doesn't share anything back with the police or the jail about the outcome of that meeting. It could just be a regular check that they do with everyone. So there's an opportunity to have that conversation. And I also wondered, with regards to Dan's point about who can do assessments, would it help to change wording so that the peer helps screen people? Or could they have a CADC person doing this work so that they could do the assessment part? Either one could be a good solution for technical assistance. I don't see any reason to withhold approval on the application, but just thought I'd bring it up.
Okay, thank you for that. Yeah, we'll provide that feedback.
Just
Any other, oh,
just
Ryan?
a brief comment that many times some of the peers are CADC certified, just depending.
Yeah, we'll provide some feedback just to make sure that the role is very clear in terms of what they're doing. Kind of getting back to some concerns that were on previous applications, just to make sure that the role of the peer support is very clear and appropriate. So we'll make sure that's the case.
One other suggestion, because it looks like they decided to have Ideal Option run their MAT program, but they have WellPath for general jail medical care, and so they could consider having WellPath also with the ability to refer to this program, because WellPath will be doing a health screening and medical assessment and all that, and they should be also identifying people that could benefit from the program.
Perfect. Okay. Thank you for that. Any other comments, feedback, anything for Springfield? Okay, recommendation to move this one forward is, there's a consensus?
Yeah.
Awesome. All right. So Tillamook, their overview is to provide screening and assessment and to monitor and treat chronic health conditions, including opioid use disorder, and to provide prescribed medications. This is an existing program. The allocated funds, $298,944. Again, meeting criteria. Staff felt like they met criteria for responsiveness on questions. Their ask is for a treatment provider services. So all of it is in the contractual services, with the exception of admin, but the contractual services category. So any comments, feedback, any clarification needed for Tillamook? Grant.
And I raised this already at the beginning, but I did want to just reiterate it on this actual application. This really, there's, given the invoicing that was done on the other, or the specific budget line that was done on all the other applications, this one really struck me because it is just, $270,000 to an organization with very little description of where that money is going to be spent. And while I understand, there will be invoicing down the road, it's kind of hard to assess a program when you don't really know what it's going to entail. And so I think, I would have liked to have seen a lot more information to make a decision on this.
Okay. Yeah, and we can ask for clarification and for detail on what they are going to be using these funds for. Absolutely. Moxie?
Similar concern about the lack of itemization of the expenses, but I would assume that's because it's bundled services that they're receiving, and they're very fortunate to have a good community partner that comes in and does all of it for them. I did think that maybe their standing monthly meeting might be a great opportunity to invite other jails to observe what they're doing, because they've been around a while and they're rural, so they face a lot of the same barriers that other counties do. So it might be really neat. And I said that about a lot of counties, like then maybe they could invite other jails just to sit in and observe their meetings to learn how they're doing it. Medication costs might be high. I couldn't really tell. It looked like they wrote down something about $4,000 per unit for a transition planner. And that was pretty much it. They might want more administrative funding because rural care can be complicated, but again, maybe it's simple because they only have one partner. And I wouldn't hold up this application. I would approve it, but it could help you spot issues if you found out about how they're spending.
Okay. Thank you for that. And the feedback to share among jails and programs, I think is something that we'll definitely pass along. I think that's a great idea. Any other questions, comments? Is there consensus to move Tillamook forward? Okay. All right, Umatilla County. Let me pull mine up real quick. So their overview is adults in custody are screened and assessed for opioid use disorders and provided appropriate treatment with ongoing evaluation while the individual is in custody. This is an existing program. Their allocated funds was $299,414. And again, staff felt like they met criteria based on responsiveness of the questions. Their ask was in contractual services, specifically a CADC, medical assistant, and medication, with a little bit of admin. So, Moxie.
I would approve the application. I thought it was great. They might need a little help with affordable medications like most of the counties. And then I did think maybe they could benefit from establishing a protocol for people who have had interrupted treatment for OUD, because they said something about continuing if there was no interruption. Buprenorphine is pretty safe and it varies. The dose that you would want to start varies depending on whether someone missed like one dose or a day or a week or a month of their buprenorphine. It's generally really well tolerated by people who are opioid dependent. So if technical assistance could help with that, I think that could save some people, because they would, when they have interruptions in treatment, that's often a sign that they're destabilizing, and that can be part of how they get incarcerated. And when they leave, they can be the most vulnerable people, and they might leave too quickly to see a medical provider. And so at least getting them out the door with back on buprenorphine, that would be a really amazing opportunity.
Okay, perfect. We will provide that feedback. Any other comments?
Just
Okay.
really quick, there's a
Go ahead.
mention on question 5 about how they're tracking recidivism. It would just be interesting to kind of know, like, are they saying like that they job well done once they attended their first appointment outside of the jail, or just something there would be just interesting to know.
Yeah, this is something that we flagged kind of, the question 5 and 6, we've kind of been using to just gather information about what people have in terms of data and potentially moving forward. And this is something that we definitely also thought was interesting, and flagged for further, I don't know, just looking into it. So absolutely.
Why was it flagged? I'm curious. Is that okay to ask?
Just from our standpoint, we're from CJC's standpoint, we're trying to get an idea of what kind of data is, because again, this is it's just a new program, and so the what is available to different kinds of facilities and what kind of data would be helpful is just something that we're trying to gauge and kind of get an idea of what potentially we could use going forward. And so this along with just other what they have access to, I think is something that we're flagging. So just in general.
Oh, yeah. I think the recidivism data would be really helpful, partly because you can get a lot of strong bipartisan buy-in to funding these programs if you address not only individual health, but the impact on the community as a whole.
Yeah, absolutely. Yeah. So, yeah, it's definitely something that we're kind of gathering that information for sure. Okay. Consensus for Umatilla County to move forward? All right. Union County. So this is an existing program. All new intakes are screened for opioid use disorder and have access to the appropriate medication. They do have telemedicine and peer support services as well. Allocated funds $316,122, and then again met criteria according to staff with their responsiveness to the questions and the letters of commitment. This application, most of it is medications and supplies. They do have an ask for an electronic health record system. And then they also have some contractual services ask as well. Grant.
I would just reiterate the feedback that I think we gave to the other place about the EHR. This one is about over twice the cost of that. I think the county sizes are around the same. And so I would sort of be curious about what this EHR system is for, whether it's limited to medication dispensing, whether it can be implemented with a different EHR down the road, and whether it makes sense for them to look into using these funds for something else for MOUD and trying to utilize EHR or trying to get additional funds for EHR elsewhere.
Okay. Perfect. Thank you. We will add that. Moxie?
Yes, thanks. I think technical support could help them, as well as any facility that plans to use buprenorphine injections, because patients can take 4 to 6 months of injections with, if it's Sublocade, the monthly, it can take 4 to 6 months before their buprenorphine level stabilizes in their blood. And so the practical impact of that is that the patient will start going through withdrawal and craving before it's been a month. So if they get 2 injections, they'll usually have withdrawal and craving before the 28 days when their injections due. So if you're discharging someone and say it's been 3 weeks since their injection, it would be really important to give them bup tablets, or even if it's been a week or 2, so that they can last and make it through on the bup tablets until they get into someone for an injection. So if you schedule them like a month out for their first injection in a clinic, they might start using drugs again before they get there, if they don't have the tablets. Or if they can schedule them sooner, like 2 or 3 weeks, then the person can give them another injection before that bup level drops in their blood.
Okay, so if we gave them some feedback about the timing of or to get some TA about the timing of that process of when they're giving the drugs and when they're when they're scheduling the next one, is that sufficient?
Yeah.
Okay.
You could probably even ask Indivior and the maker of Brixadi. I have no financial interest in them, by the way. You could have them offer that technical training, because they'll visit sites and tell people exactly how the pharmacology works and what are the day-to-day needs that staff has to understand.
Okay, perfect. Thank you. Any other comments, questions, concerns, any other feedback for Union County? Okay, consensus to move this one forward? Perfect. All right, Yamhill County. Their proposal overview is to provide opioid use disorder treatment and transition planning services to individuals in custody who are not previously established. And this is an existing program. The allocated funds are $242,047. They did meet staff felt like they did meet criteria for responsiveness, for letters of commitment and the questions. And just to note, because it is, hold on, let me just make sure I'm not previously established individuals. Okay, yeah, never mind. I just wanted to make sure I said that correctly with the proposal overview. And then their entire ask is in treatment provider services in the contractual services category. Any Grant?
I'm just gonna have that same feedback about the need to actually spell out what you're spending money on, or detail how that money is going to be spent. It's very important. And yeah, this is the same as the others.
Perfect. Okay. Moxie?
Yeah, mine was more about the program and how to make it so that it's sustainable. I think if they're not at their maximum amount that they can request for their budget, they might want to add administrative costs to their budget, especially if they might work with multiple opioid treatment programs. Those are very bureaucratic settings. It can take a ton of work just to treat one patient. We used to spend sometimes 2 hours a day working on getting someone's medicine to them at an inpatient medical place where everyone knew how to give meds. So it was, it's quite a heavy lift for both the OTP and the jail. The other thing is they might want to have an LPN because an LPN is allowed to pick up methadone in the chain of custody regulations. The State Opioid Treatment Authority, Dr. McElveen, could advise the jails about who's allowed to carry the methadone from one place to another. So if they were able to get an LPN that could work in the jail regularly on other things and also do the transport of the methadone, that would be great. And same thing about itemization of costs. It could help with quality improvement. Thanks.
Perfect. Thank you. Any other comments on Yamhill? Okay. Recommendation to move this one forward. Is there a consensus? Okay. All right. That is all of the applications. I do want to have a discussion. I know it has been a very long meeting. I just want to have a short discussion about supplemental and next steps. But first, before we do that, I just want to offer public just a moment for public comment. If there's anybody in this meeting that is a member of the public, this is your time where you can comment should you choose to do so. Keep your comments brief, 1 to 2 minutes, and just keep in mind that we are not able to answer any sort of questions or anything like that. So just keep them to comments. And I'm not seeing anybody. You can just raise your hand if you'd like to. Okay. All right. I'm going to stop presenting. Thank you all so much for that. That was incredibly helpful, particularly feedback. I think this is going to be a great way to continue the conversations with these applicants, grantees moving forward, and just all of the things that we've talked about today that are simultaneously happening. I think these conversations are incredibly important. So appreciate your engagement with that and reviewing the applications and all of that. This has been a very productive meeting. Just to circle all the way back to Orion's question in the beginning, Captain Eby, thank you for sending me this list. But the counties and facilities that did not apply: Coos County, Deschutes, Harney, Jefferson, Josephine, Klamath, Lake, Lynn, Polk, and Washington. And so we, with that, we have a couple of things. We have an ask of 6.7 million, little and some change. So there is some, there are some funds that are left over. We also have some counties that didn't apply. And so with all of that kind of information in that context, just wanted to have a brief conversation. We don't have to get into too much detail, and also don't necessarily need a recommendation from y'all today. We can continue having this conversation. If we end up on one, that's totally fine. About the supplemental round and some potential options or thoughts or any feedback that you all may have for CJC staff in terms of how to approach a supplemental round for this. Just for some context, the supplemental round would typically, it occurs halfway through a grant cycle, and so that would be sometime in spring is when this would open up. So a couple things to consider is spending. Would they, having the ability to spend the money in the time of the grant cycle, and then who potentially could apply for those supplemental funds. So one thing we are doing as staff is the facilities that did not apply, we will be reaching out. We have reached out to a few of them as to why they didn't, and just to kind of get an indication of any sort of feedback on that as well. So I will stop talking. If anybody has any thoughts, be great if you could share them if you would like to. Captain Eby.
Well, there's multiple ways. Obviously, one thought would be to utilize the similar formula that we did in the first round to those that have applied, to offer that amount to those ones who've already applied. That would be one. One would be obviously to open it up to those that didn't apply in case they want to apply again. But I think that still will leave money on the table at the end of the day, potentially. But I think if you're looking at the ones that have already participated, obviously you took the time and you want a similar formula, so a similar process, so we're not recreating another wheel, would be just to use the same type of formula and say, here's what supplemental funds are available to your county, and go from there.
Okay. Okay.
All right.
Orion?
I'm a little disappointed that some counties didn't choose to apply. I don't know all the reasons for them. So some of it might have also been like the turnaround to get a grant application and proposal together. So I would hate to exclude those people from further conversations because they didn't do the one now. I also think that there might be some additional lift to submit a secondary application, go through a secondary application. So although I like the formulary that allows for people to know what budget is there and not really competitive, it might be that the group could consider something that is a little different for those that then want to go beyond this for supplemental. So maybe it is competitive and it's based on the groups that chose to add to what they did, and maybe this group would then be able to decide if what they're trying to add is a worthwhile addition for those extra funds. But that's just my own opinion.
Okay. Moxie?
Yes, I just wanted to say, I think that I think some of the places that don't apply might imagine that the process is much more difficult and that we'll be much stricter in the grant review process than we are. So I wanted to offer that I could go and visit some of these programs and complete their forms for them, for probably several of them over the next month. If they were able to submit them by mid-December, I wonder if we could review them in January and get the funding out the door.
So a couple things on that. If as an advisory committee member, you couldn't physically help them fill out their applications, you could provide TA. Obviously, you can have conversations with them about how to do it. The timing of getting the funds out is there's a lot of things at play. part of it is the commission will ultimately make this decision. We just wanted to get feedback from you all, mostly because you've been involved in this process since the beginning, and so have a really good indication of what it would look like for people who didn't apply, this process, what it entails, all of those things. And so we would have to have them approve it. So the timing of that, and also getting these funds out, and then the lift to get a supplemental isn't as great as the lift to get this grant program going, but there's a lift for staff, and it's probably not feasible to do it by January. The other thing too is if we decided to just go with those that didn't apply, it would be a different process than those who have already applied. And I also just wanted to mention we could split it. And so if you wanted to open it up to those who did and those who didn't, that is also an option. We would have to kind of discuss what that looked like, but that is also something that is potentially could happen. So, Orion.
I wonder if it would be helpful for me if I could get that list that Captain Evie had, if you don't mind. I know for like Deschutes, they're using Measure $110 to have ideal options comes in, and so maybe they didn't apply because they already feel like they have a functioning program. So it feels like there's and like places like Harney are just so small and strapped, and like their jail commander doesn't have time to answer an email usually. So I wonder if there would be ability to do some outreach to the jails that did not apply to see if they would be interested in considering this in a supplemental opportunity first. Yeah, go ahead.
Yeah, we will be doing that. Staff,
Okay.
CJC staff will be doing that for sure. We'll be reaching out to them and getting feedback on this whole process and why they didn't, and whether or not. Purpose of this, and again, we don't have to continue with this conversation. I just wanted to see if you all had thoughts on the way that a supplemental would work. There's a lot of options. We also have to consider what's in the bill versus what's in OARs. So there are some things that we have to consider in terms of process, but I just wanted to get your thoughts on this. But yeah, no, Orion, we will definitely be reaching out to them for sure.
I should have figured
so
that.
No, that's okay.
That might change the conversation based on you hear that, that X number are going to actually be interested in making an application. And
okay.
Cool.
Absolutely.
Happy to come back together, I guess is what I'm saying. If you, after that outreach, if you wanted to have this conversation again.
Okay, perfect. Okay. Daniel?
Yeah, I was just thinking about the intersection with the needs assessment work that OHA is doing regarding the waiver, and maybe some of these jails already indicated where their gaps are when it comes to MAT services that could also be insightful to take into account. I think just from looking at names on the list, a lot of those jails, I don't think have a lot of MAT services going on right now. And so if I guess I would prioritize giving them a chance to start something, and probably that feels hard to initiate for them. And there's like a funding opportunity, but funding is just part of what you need to build a program. So I think they're maybe acutely aware of some of the challenges, or started to think about that with the solicitation, but there's just some big challenges. One suggestion I had is to do some like paired outreach to health providers or behavioral health, like the CMHPs in each of those counties, and maybe even try to have specific conversations. Have you approached your jail? Who are the possible like entities that could do programs? But I think it just may be hard for some of these jails to jump on the application without really getting talking with all their medical partners and knowing that somebody wants to do this and help them do it.
Okay. Yeah, I think that's good feedback. Also, your point about everything else that's happening at the same time as this, I think there's some, it makes sense to consider that as well. So for sure. Moxie?
Yes, excuse me. I think of the people who didn't apply as a high priority, but I also could see a role for saving some of these funds to help jails meet expenses when they're going over. And so I think a high yield area, especially because it causes so much problem with health equity and morale among the staff and patients, is that we might reserve some of the funding to say in the last 3 or 4 months, if you've underestimated the expense of the medications, you can let us know and we'll give you some funding to help you, buy more injectable medicines, because there's nothing worse than seeing that, 40th patient when you've just run out of the injectables and you have to say, I know your best friend came in the other day and he got it, but you can't. So that's a challenging thing with grant funding. Thanks.
Yeah. Okay. Mitch?
I really want to back what Moxie's saying too. And I think this is an opportunity for a little bit of TA for an unfamiliar process, because I think we could be helpful to say like, and do it when you've reached, 5 remaining doses or 15 or whatever the remaining dose point is. Because I think the inventory systems is kind of where a lot of new programs tend to falter.
Okay. That's great feedback. Perfect. Okay. Thank you, all of you. If anybody else has any sort of comment they want to make, this is the time to do it. Dan?
I beat out Orion by a millisecond. Yeah, I was going to ask about the confidentiality basically of the grant application materials, and from a TA perspective, like many TA needs were identified, and are these applications shareable or to like a limited extent, or how should we consider that?
Yeah, that's a great question. So there's nothing, this is a recommendation to the commission, right? This is kind of the process. So this is exactly what I was just about to get into. So we will take kind of the next steps is we will take feedback, we will take your all's recommendations and communicate with the applicants at an appropriate time. There is a process where it goes, we'll let them know you all met. We'll let them know that, their application's moving forward, and kind of all of this at this time probably won't provide a lot of detail. The commission will then meet. The commission meeting is November 20th, just so you all know. So like I keep saying November, that's the actual date. I will present your recommendations to the commission. The commission then decides whether or not to fund. And then what we do is then we enter, there's a protest period that we have to kind of enter. We let them, the applicant know, like, this is the decision of the commission. There is a period of time where they are able to protest. And there's some process there that there's a little bit more detail to that I won't get into now, but there is that period that we do have to consider. And then after that, grant agreements can go out, and there can be, signatures and all of that, and then funds go out. So that's kind of the process. So my recommendation is to not share anything until the commission makes a decision. And the reason why is because should the decision be different from this recommendation, there's a lot of backtracking that then has to happen. And so the feedback and the TA will occur, and it will be something from CJC and communication. You all can obviously be a part of that. But as of right now, this is just a recommendation. And so just be very careful if you do have conversations to make sure that your language isn't that this is set in stone. There's still a part of a process that has to occur before that.
Yes.
So did that answer anything?
That's helpful. Maybe I can just say like concretely what I'm talking about, and I think I would still go ahead with this information is I have another doctor on my team doing the TA, and there's a couple of the jails that I think we would want to proactively start talking to them about applications that they're making a brand new program or big changes. And so I'd be including this other doctor who's not on our grant review committee to be able to see what the jail applied for. And I can help all of us understand in the TA context that these are not set in stone and that the funding is not confirmed yet. But these are just a good record of what the jails want to do with the funds, essentially, and it may lead into that.
Yeah, just be very careful in conversations with anything to do with funding that it's not a go ahead, that it's if the TA, you want to just make sure the TA is process oriented, right? In terms of here's a process, here's some feedback on process. I would leave the conversation about funds alone until there's an actual here's what you're getting.
Yep,
And then have those conversations. So
yeah, program design is what I wanted to start working on with
yes,
some jails.
yeah.
Yep.
Okay. Orion, do you have your hand up?
Yeah, I'm on the phone, so I can't really.
That's okay.
Lower it, but I wondered, yeah, like to Dan's point, I feel like you guys need to take this back to the commission. I am just going to sit with this, but I'm going to, I still am going to be having conversations with the different jails. Maybe we can also be, and so there is TA that is going to be starting with the jails in the next couple months for the waiver work. And so I think there's some conversations to be had with you, Rachel, and to our waiver team, just to make sure that things are there. They do have these assessments, which include MOUD that just went out to the jails. Maybe there's option to share back and forth the application. Internally, we would not share that out. I wouldn't plan to say, hey, I read your application and I saw this. But as we think about TA, it might be less overwhelming if we kind of coordinated some of that so that as our waiver people are reaching out to have TA, if there are people that need they want any TA or support for peer programs, and with Sharmali, if OHSU, but I don't know, kind of some way to package all that together so that it's given to the commanders and given to the jails in one dose so that they can see kind of these are the different.
Yes, I just want to caution all of you to just we are in a holding pattern and just be very be patient with what happens after this meeting. We do have to sit on this until the 20th. There's not a lot of conversation you can have as it relates to funds. This is just a recommendation. So when we talk about TA in a bigger picture, you got to kind of sit on it until our process is done, and then we can kind of have those bigger picture conversations. The feedback and all of that to grantees or to applicants is for the purpose of here's how the process is going to go as you move through the life of this grant, right? And so it's not appropriate to share that right now for CJC to share that right now when we are just kind of moving with a recommendation, if that makes sense. So this is, absolutely. I encourage you all to just have, as it relates to this grant, have some patience in terms of conversations. I know there's a lot going on. I know there's a lot of things moving. You got to just be careful with language.
I don't want to get ahead of the board making the actual determination or anything that has to do with this grant. But just so you're aware, the TA for the waiver probably will be starting before that meeting.
Yep, that's okay. Yeah, we know that. But from our standpoint, we don't want to speak outside of our process and how it functions within the commission. So, yeah.
Rachel, what exactly did you mean when you said TA about the funding? Or I didn't know quite what you meant when you said that.
I wouldn't say anything that has to do with any recommendation for funding at all. Because it could change. This is just simply the commission can do whatever they want. They can decide how to fund this. Okay. This is simply a recommendation. And so if you're talking about funding in the sense of this is what is going to happen, we don't know that yet. And so we are in a holding pattern until the commission actually makes that decision. So my job is now to take all this information, put it together, put it in a presentation, go to the commission and say, this is what the Grant Advisory Committee recommends for funding for these particular facilities in this particular way. And then they get to ask me all the questions and then have a conversation, and then they make the funding decision. So I understand that there's a lot of things that are surrounding this grant program. I caution you all to just sit on it. Have some patience with this process, because we can't speak to it either. So just be
Yeah.
aware of that.
I think the reason, at least that I'm talking about this now, is because some of the jails, like the Eastern Oregon jails I've worked with, we did TA with them for an entire year before launching their MAT program. So a jail that says we're going to start a new MAT program in like February that still has a good amount of time on this grant, they like urgently need to start planning, in my opinion, as a TA provider right now in order to figure out how they're going to do that. And we can't like delay till December and think they're going to launch in February realistically. So that's kind of where like I would want to start talking to them about program design and what they want to do essentially.
That's fine. Yeah.
Okay.
Just don't make any assumptions about funding.
Yeah, that's fine. I can hold that uncertainty.
Okay. Moxie.
Yes, thanks. I just wanted to offer that if it would help you in any way to kick me off of the grant advisory committee and have me go volunteer to do these applications with people, I would be willing to do that. So just let me know. And then the other thing I wanted to say is, Rachel, you've done a fantastic job facilitating this. I hope that you don't have meetings like this every day, and that if you do, you get a week off every time this happens to you. You did
Thank
great.
you. This does not happen every day. It does happen every few months or so. But yeah, no, I appreciate your all's engagement. These meetings are long, and there's a lot of information, and there's a lot to kind of talk about and be consistent and things like that. So I appreciate you all just being willing to have the conversations and be collaborative and moving forward. And I know there's a lot going on. And so also, the meeting started at 8 a.m., which is always really rough. So hopefully you got enough coffee. At least it's not 8 a.m. on a Friday. We tried, right? We do have to, the big thing for us when we schedule meetings is getting quorum. So sometimes it's just kind of like, here's when we have to have it. And so, yeah, appreciate all of you. I will be in touch in terms of next steps with the supplemental, what's decided, if we do need to meet, if we need some sort of feedback from you all for that. Definitely be in touch for that. But yeah, a reminder, the commission meeting's on the 20th if you want to listen in and see how it goes, so that you can get an understanding, and then we'll be communicating with the applicants with all of this feedback, and then also the funding decisions. So awesome. Enjoy the rest of your day, and thank you so much for your time. We'll see ya.
Thank you
Bye,
all.
thank you.